Step one.
She said it. She said it.
She just said it's one of those things.
She said it.
Today's Monday.
Uh-huh. It is Monday.
I'm just completely dead. Okay. All right. Good morning. Good morning. Good morning.
Good morning.
Everybody ready? I know we're a few minutes late. Happy Monday. Anybody have any questions on what you read on your homework? Any questions on chapters 2 and 3? I know it was a lot.
Oh yeah. Chapter 2 was longer than chapter 3.
Yeah, very long and not overly exciting. I know.
Especially at the end. I was like,
Yeah.
I think I've done all this.
Yeah, I know. It's not the most engaging of content, but it is stuff that you do need to know. So thank you for getting through it. Let me get your scores for chapters 2 and 3. Jessica.
Chapter 2, I got a 90, and chapter 3, I got 100.
Thank you. Gianna. Gianna here. Cheryl.
I have a 95 and a 90.
Thank you. Ashley. Jacqueline. Gabriel.
I got a 90 on the first one and 100 on the second.
Thank you. Kayla.
100 and 100.
Thank you. Lindy.
90 and 100.
Lindy, do you have one for me?
Got what?
Chapter 1. Somehow I
I
missed
have
it.
100.
Okay, thank
No,
you.
I was late that day.
No worries. Paula.
195.
Thank you. Dwayne. Thank you. Faith.
Pass.
Thank you. Roque.
100 and a 90.
Thank you. Griselda. Lewis.
Pass.
Rebecca. Okay. All right. So no questions on any of that? No questions? So tonight, your homework is going to be chapter 4. Chapter 4 is on body systems. It's not a very long chapter, but it is a very complex chapter, I guess would be the best way to put it. A lot of students get a little overwhelmed by the amount of content in there. The biggest thing about body systems I need you to understand when you're reading that chapter is that there are roughly 9 recognized body systems. They all have a different job to do, but they all work together. So if something goes horribly wrong in one body system, chances are it's going to have some kind of an effect in another body system. So think of it like collateral damage, right? So if you grew up in a family with a mom and mom was not happy, Everybody in the house knew it, right? Right? Cabinets got slammed.
You were relaxing.
Yeah. Yep. So it's kind of like that. When one body system has a problem, it kind of lets everybody know that, hey, there's a problem. And you can have issues in other body systems as well. So I need you to understand that they all have their own specific job to do, but something that is affecting one body system will usually have an effect on others. So what that means, if we have a patient who had a stroke, which is a disorder of the circulatory system that has a nervous system effect, it may actually affect your urinary system or your respiratory system or your musculoskeletal system. So it may have a bleeding over effect. Okay. So good. You guys understand that? Second thing you need to take away from chapter 4 is normal aging processes in the elderly. Because remember, half of our job is to observe and report. If we don't know what's normal, it's hard to know what to report. Okay. Thinner, drier skin in the elderly, very normal. You don't have to go to running to the nurse every time you see thin skin in an elderly person. That's normal. Now, open skin is not. Does that make sense? So you kind of have to know normals, and that's what I want you to concentrate on with chapter 4. You don't need, chapter 4 goes into detail about what diseases affect what bodies. You don't need all that. That's not really the domain of the CNA. All right. So before we get into today's topics, and we have 4 skills to learn today, it's going to be a very busy day. Before we get into that, we want to do a quick review because it was the weekend, and I want to make sure that you remember everything we learned last week so that we can apply it to this week's lesson. So this should be very simple for you. How do you know what to do with each patient? Yeah, we follow the care plan, the whole care plan in. Okay. Half of our job is to observe. And then who do we report those observations to? Yeah, you guys remember all this, right? Okay. Remember that the care plan has to be followed exactly for every skill on every patient every time. Super important. So every skill starts with an opening. What does every opening start with? A knock, correct. We're going to greet who? Who are we greeting? Patient, because it's always about the patient. Remember, nice. We want nice. Anybody ever, this is really dating myself. Anybody ever see the movie Roadhouse?
Yes.
With Patrick Swayze? Yeah, I always think of that line from that movie. We're nice. We're nice. We're nice. Until it's time to not be nice. As CNAs, we don't get to make that determination. We would take it to the nurse. If we feel like it's the time to not be nice, we would take it to the nurse. Okay. How do we know we have the right person? There's no ID bands in the test. How do we know we have the right person?
Would it be on the care plan? Like tell them.
Depending, but you should be greeting them and going through the steps in order to find them.
Okay. All right. So it could be on the care plan it might be how to identify the patient. We need to go through the steps, but I heard somebody over here say their name. Yeah. That's what we're going to do here. We're going to call them by name. For the test, that's the easiest way. And it works in clinical settings too. Most people respond to their name. You guys know that that's like the first thing you learn about yourself. You learn your name before you learn where your toes are. You start to respond. Anybody ever have a baby? They start to respond because we use their name all the time when we're doing little baby talk and activities and stuff. It's the first thing you learn. So even later in life, you tend to respond to your name. It's the first part of your identity that's established. So we continue that throughout, clinical life, even with dementia patients. You want to continuously use their name. There's two reasons for that, guys. The first is when you're working with dementia patients, you want them to reorient. That's the term. So it's orientation therapy, right? You want to try to get them as aligned with person, place, and time as you can. So by calling their name, it reminds them of who they are. The other thing that it does is it restores the humanity in the interaction. Because, and I've seen this happen, it's a very strange dynamic, right? We know that that's a person over there. But if she has dementia and she's not responding and she's kind of locked in, right? We tend to dehumanize her. We tend to stop looking at her as a human and start looking at her as a job. When you start using their name repeatedly, that's Mrs. Hayes. Mrs. Hayes liked this. Mrs. Hayes enjoys this. When you start doing that, when you start restoring that humanity, it actually elevates the level of care. So when you're working with dementia patients, even if they can't respond to your name, it's important, or to their name, it's important to continuously use it anyway for you. Does that make sense? Good. All right. Oh, where'd I go? Come over here. Oh, there I am. Okay. All right. So what do they need to know about us? Name and title. Yeah. So not just, hey, I'm so-and-so. Name and title. Uh-oh, what happened? Okay. So what are we going to describe to them? Yeah, our skill. What are we, what we're planning on doing with them. And then what do we need to get from them? Yeah, consent. Absolutely. After we do all that, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA. I'm here to whatever. Is that okay? I've now got their permission. What's the next thing I'm going to do? Why can't I do that in the beginning? Why can't I walk in the room and close that privacy curtain?
It's like taking your date home and closing the door and locking it. You don't want to do that.
Yeah, good point. You don't want to do that, right? Because it kind of removes their ability to determine what's going to be done, right? It predisposes them to whatever you have planned. And that's not really the impression we want to give here. So we want to get their consent before we close that curtain. Very important. So is that curtain clean? No. So what do we want to do after we touch that curtain? Wash our hands. Okay. And then once we wash our hands, we're going to gather our supplies. Now we have to get the supplies after we wash our hands because we want clean hands to get the clean supplies with. Yeah. And, it all boils down to what kind of hands would you want to be touched with in a clinical setting, knowing that all the other people that these caregivers have touched have all kinds of cooties that you don't currently have. What kind of hands do you want to be touched with? Right. So remember that every skill starts with the opening and the order does matter. So let's talk about gloves. Do we wear gloves for absolutely every skill, every time on every patient? Why don't you want to do that? Man, that's easier. I spent over an hour talking to you about gloves on Wednesday. I could have really shortened that lecture and just said, wear gloves for everything. Don't worry about it. That's right. Cross-contamination, because we stop paying attention. The longer you wear gloves, the more things get through. Your surface is warm, dark, and moist. So you're proliferating that bacteria. There's just a lot of really bad problems with walking in a room and throwing on a pair of gloves without thinking about it. And the number one problem is we stop thinking about it. So we can't just routinely wear gloves for everything. And you'll see a lot of people in healthcare do that. I need you to be just a little bit more self-aware than that, because I might be the body in the bed one day.
I do have a question.
Sure.
If you do see a nurse aide working, and you see that they go in, they don't wash their hands or nothing. They shake hands with you. I'm not speaking from experience or anything.
Right.
Nothing personal. But then they go and they put on some gloves and go touch the urinary, the stuff with the pee cup,
Mm-hmm.
the toilet bowl. They just dump it in the thing. They don't wash it. They just put it back, and then they take their gloves off, walk out. They don't wash their hands. What do you do about that? Do you say anything, or do you just?
So here's the problem. And I wish I could give you the answer that I want to give you, but I can't. As CNAs, we don't really have the authority to correct anybody. That's not really our role. We can be an example. If somebody asks us, we can certainly explain why. We can voice our concerns to the nurse. Remember, we always report all observations to the nurse, but we won't go to that other CNA and say, hey, dude, you're cross-contaminating everything around here. Let me show you how it's done. Let me tell you a story about this. I was a young person once, and I took home economics. This is back when home ec was a thing in schools. And they taught me how to use a measuring cup properly. There's a measuring cup for liquids. There's a measuring cup for solids. Don't use, them interchangeably. So I learned all about how to use measuring cups, and I went home all excited and explained to my mother how all of these years she has been using measuring cups wrong. The woman who feeds me every day. And because I had a little bit of new knowledge, I was so excited to share it with her and tell her how wrong what she was doing is. How far do you think I got? Not very far. No. In fact, I'm a little older now, and she still brings it up. So, you, in this case, are the student who just gained a little bit of brand new knowledge. And you're excited about your brand new knowledge, and it is absolutely correct, brand new knowledge. But if you go to all the CNAs that have been working out there for a gazillion years and try to explain to them why what they're doing is wrong, you're not going to get the reception you think you are. They're not going to go, oh, really? I didn't know. Let me check. No.
Well, what if you're the patient's family?
Patient's family, speak up. Absolutely speak up. So I'll give you a great example. And a coworker of mine currently has a family member undergoing chemotherapy. They're wiping out the immune system. And the family member is currently in the hospital. And my coworker is sitting there watching. Now, they're actively wiping out the immune system, right? This is very dangerous. And she's watching caregivers walk in and not take the infection control steps that she knows needs to be taken. Now, if she doesn't speak up, this could absolutely take her family member's life. Should she speak up?
Yes.
Absolutely. Absolutely. Yeah, as a family member, I'm very tactful, but I absolutely advocate for my family when they're, in a clinical setting. That's my job. It's your job as a family to speak up.
Okay.
Yeah, absolutely. I went so far when my mom was in the hospital to put a sign up, do not touch this patient until you've physically washed your hands. And I made sure that the doctors complied as well because she was septic. And I knew one more pathogen would kill her. That's my mom. I am absolutely going to take that step with my mom. Make sense? But when it's a coworker, it's a different thing. You got to work with these people, right?
Mm-hmm.
But you can certainly mention to the nurse, hey, I've noticed some infection control issues, and I just want to make sure that I'm doing it right because I know I'm new. You can play it off that way. That's fine. But, there's a tactful way to do it. You don't want to run down the hall and tell the nurse, do you know what she's doing down? You know, that's probably not the way to address it. All about tact.
It's not what you say, it's how you say it.
A lot, yes, absolutely. A lot of communication is the delivery method. So, but yes, you can address this for sure. Yeah. So when are the 3 times that we do need to wear gloves? If we're going to be touched, body fluids, open skin, and personal skin. Yeah, anything covered with a towel. All right. I was literally setting this up at 5 o'clock this morning, and I think I missed some buttons because I didn't have enough coffee. All right. So the first thing your gloves should touch is the patient. Keep your gloves clean for the patient. Don't put your gloves on, touch a whole bunch of stuff, and cootie those gloves up, and then try to put those gloves in somebody's mouth, because that's just gross, right? Just gross. All right. Then once you've used those gloves, you have to pay attention to what those dirty gloves have touched. So be careful about cross-contamination. I call that pay attention to those pesky pathogens. They'll get away from you. We have to remove the gloves correctly so that we don't contaminate ourselves when we remove them. How do we remove gloves?
Pinch the palm, peel,
And then you
sneak
go
under.
Very good. Pinch, peel, sneak, and remove. Good.
Sneak.
Sneak under. Yeah.
I like that.
Okay, remember, gloves are not a magic suit of armor. Once you take them off, what do you got to do?
Wash your hands.
Wash your hands. Yeah. All right, so we're going to move on to barrier. Tables are not clean. So what do we need?
Barrier.
Yeah, a chuck's a barrier. Is there anything else that can be used as a barrier if you don't have a chuck's available?
Paper towel.
Yeah.
Anything sterile, is that what you said?
Doesn't even have to be sterile, just clean.
Disinfected?
Yeah, paper towels, bath towels, washcloths. Clean. That's all I'm looking for here.
Clean stuff.
Yep. So we need a clean area to put our clean supplies. Remember, the clean supplies have to stay that way until they're used on the patient. So we can only touch clean supplies with what kind of hands? Clean hands. Yeah. What can we not hold our supplies against? Why? Yeah. Don't you love my little pathogen, guys? I had so much fun building those. So the order matters here. You've got to go get the barrier first, put it on the table first, then go get your supplies. The reason that we do it that way is if you're trying to hold those supplies while you're spreading out that barrier, you're going to end up contaminating those supplies. They will be held against. You won't realize it. You will not realize it, but somebody else will. And you don't want that somebody else to be the evaluator during the test. Okay. So a barrier is used anytime we use supplies. So let's talk about linen rules. Boy, we learned a lot, didn't we? Learned a lot. So what is not clean once you start work?
Your clothes.
Yeah, so we can't let anything touch our uniform. You have to have clean hands to get clean linens. We've talked about that. Remember, if it shows up on more than one principle,
It's probably important.
it's really important. Yeah, it's going to be a critical concept step. Yeah. So what do we not do with linens? Snap or shake. Why? Everywhere. Those pesky pathogens. Yep. So what if we take too many linens and we don't use them all? Can we leave them in the room for later? Okay, so we're going to use it or lose it. Yeah. Remember that items out of your sight can't be considered clean. People will do all kinds of things with those linens and you won't have a clue. So let's go on to privacy blanket. Your perception of temperature is different from a patient. So we're going to use a privacy blanket to keep our patients private, but also warm. That's correct. So I want to talk about this real quick. Privacy blankets are not going to be on a care plan. There isn't a care plan in the world that's going to tell you, go get a privacy blanket and use it. It's just not going to happen. This is considered a basic nursing principle that you're supposed to know. Now, the reason that I made this slide is because this came up a couple of classes ago. Somebody said, well, it's not on the care plan. But I want to kind of point out that everything on that back wall is not on a care plan either. The care plan is not going to tell you to do the opening. It's not going to tell you to get consent. The care plan is not going to tell you to use a barrier. You're expected to know that. Care plan is not going to tell you when to wear gloves or how to remove them. The care plan is not going to tell you when a privacy blanket should be used. So everything that we're learning so far, all of these principles, these are things that are not going to be on the care plan that you need to know.
Isn't the standard precaution?
Standard precautions is part of glove rules, so it's not on the care plan. It's universal. Good? Does that make sense? And that's why we review these, because this is the information that I need you to know, because it's not going to be on the care plan. Okay? Good? Okay. So when we put a privacy blanket on, do we take the sheet completely off and then put the blanket on? Why?
Because then they're exposed.
Yeah, exactly. Defeats the whole purpose. We want that patient covered. So how we put that blanket on actually matters here. And we already know this one, don't snap or shake. When we remove a privacy blanket, we do it after we remove our gloves. Think about all the things those gloves have touched. That sheet is going to go right up next to the patient's face where there's a lot of holes. Remember those doorways in? We don't want all those pathogens on the sheet right next to our patient's doorways. Please remember that two of the most important principles that I'm teaching you in this class is about comfort and dignity. It doesn't do us any good to learn how to do the skills if we're not doing them humanely. Does that make sense? So basin cleaning, all basins get cleaned the same way. We know how to clean basins. For the test, we're just rinsing them, drying them, and storing them. But a question that comes up quite a bit is, where do you dump the contents? Well, that's easy. Where they would normally go, right? So you're going to empty everything into either the sink or the toilet. Remember that you can't hold a basin if you're going to be disinfecting it. Gloves are dirty. Can't be spraying a basin with dirty gloves. So we're going to set it down, and then we'll use a paper towel to pick it up between our dirty glove and the basin. We need a barrier to prevent that cross-contamination. Then we're going to dry the inside and the outside, and then we'll get a paper towel to get our supplies and store it. After you've done that, you want to throw those paper towels away. You're going to see this again and again and again. It'll get better with repetition. This is one I kind of speed through because this is kind of hard to take in unless you're doing it and seeing it. Remember that all basins are cleaned the same way. And then finally, we get to the closing. So guys, we have mastered half of the principles on that back wall. We're going to learn a few more today as well. So our big rule here is always leave your patient looking better than you found them. So how should our environment be when we leave? Clean. Sure, absolutely. What position should the bed be in? Low. Right, because that's safe. What word do they need to hear? Yeah, are you comfortable? And we're going to go a step beyond asking, are you comfortable? We're also going to offer them a magazine or reading material or something. Give them something.
Could you offer a remote?
Sure, absolutely. Absolutely. But you want to address that comfort, that emotional comfort. Head of the bed at the end of the skill is always patient preference. They may want to sit up to do the crossword puzzle book. They may want to lay down. I want to lay down, take a nap. Head of bed down for me today, please. It's all about comfort. So we're all done with the skill. Don't need privacy. So what can we open? And then how are they going to get in touch with us if they need us? The call light. So we're going to do all of those things, and we don't care what order you do them in. Make sure your patient is in a clean and safe environment. Make sure they're comfortable, both physically and emotionally. Open the curtain, give them their call light, all of those things. And then once you're all done with those steps, what do you need to do?
Wash your hands.
Yeah, get rid of those cooties, clean those hands. Now, if you have to document, when do you want to document? Before or after you wash your hands? Okay, after you wash your hands. I know it was a trick question, wasn't it?
Yeah.
Because what do you do after you document?
Wash your hands.
Wash your hands. So the answer to that question is both. You document after one hand washing and before another. Okay. So document and then wash your hands again. So remember that our checkpoint here is that you have to end the skill with clean hands, but you also need a safe, comfortable patient in a clean environment. Okay, good. It's important to make our patients feel cared about as well as cared for. All right, so we're going to move on to page 116. There we go. That's better. All right, so we're going to get into a new skill today. This is provide hand and nail care. This has got a lot of principles, guys. If you look down the side here, all of the principles that are covered, skill rules are going to apply because skill rules apply to everything. So does the opening. So do glove rules. This skill has supplies, so we need a barrier. Linen rules are going to apply. You don't want to hold those linens up against your uniform, and you got to know where to put them when you're done. We're going to wash something, so we have to learn some washing rules now, and then we're going to clean the basin as well. We've got some skill-specific things to go over and the closing. So when you're looking at this, there are a lot of principles involved in this skill. So if you go to the next page, page 117, I don't have it up here, you'll see all of the steps involved in this particular skill. There's a lot of steps as well. So if you look at the care plan at the top of page 117, and I apologize, I don't have this slide up for you. But if you look at the care plan, it says to provide hand and nail care to one hand. Let's stop there for a second. What if our patient has two hands?
Oh, man. It's not in the care plan.
Yeah, do we care? No. Care plan says to wash how many? One. Are we going to wash the other one too? No, we're going to follow the care plan, right? So some of you are going, well, wait, why would we only wash one? That's weird. Which one do I wash? If the care plan specifies, we follow the care plan. For the test, they're not going to specify. It's just going to say one hand. You get to pick. They don't care. They figure if they watch you, soak one hand, wash one hand, rinse one hand, dry one hand, clean under the nails, file the rough edges, and lotion one hand, they don't need to see it on the other side because those evaluators don't want to be there. Where do they want to be? At home, floating in their pools, drinking their Mai Tais, and you are standing in their way. So one hand is all we need to see here. Good. For the test, they probably aren't going to tell you which hand. You'll get to pick one, doesn't matter. But let me give you some examples in a clinical setting of why this might say one hand. If we have a patient that's getting ready to have carpal tunnel surgery, we probably don't want you on that side because we're going to do a betadine scrub, and some of the soaps can interfere with that, or a chlorhexidine scrub. Some of the soaps that are used can interfere with that. Or maybe the patient has an incision on that side. We don't want you working anywhere near that. Or maybe the patient has a bandage from a skin tear. We don't want you getting the bandage wet. There's a lot of reasons why I might write a care plan that tells us to do one hand. We don't really care. We're just going to follow the care plan. Good? Okay. Tells us the care plan goes on to say the patient is sitting in a chair at the bedside and can move as directed. So I want to kind of point this out to you because students are pretty universal in this. You guys always go worst case scenario. I don't know why you do that, but you do. And you will envision, okay, if I'm going to do hand and nail care, this must be a stroke patient slumped over in the chair, unresponsive. That's not what this is. This is you. You just need one of your hands washed for whatever reason. I don't know why. I don't care why. Care plan says to do one. I'm going to do one. But let me explain to you why we're actually doing this in long-term care. You're not going to do hand and nail care in the hospital. This is not a hospital skill. This is long-term care. Anybody know, like nail clippers? When your nails get long, you grab those nail clippers and you trim them down, right? Has anyone accidentally cut the skin when you're clipping your nails? Especially if you're trying to clip somebody else's nails, like a kid. Cutting that skin is super easy to do, right? So in healthcare, we don't want to cut nails because the risk of injury is actually pretty high. It's not really a job that we want. And in fact, we actually restrict CNAs and don't let them use nail clippers. It's not really your deal. So instead of ignoring the nails, I'm getting long, and then taking a sharp object to hack them off, we're going to do hand and nail care. And that files the nails on a regular basis, usually twice a week. And when you do that, it keeps the nails at a manageable length so you never have to use nail clippers. That's why we're doing this. We're doing this to prevent the nails from getting out of control. We're also cleaning the nails with an orange stick as well. Good? So this is something you would be doing more in long-term care because we're trying to prevent a problem. And if you remember, I told you on the first day that as the RN, I go in and do a head-to-toe assessment, and I'm looking for all real problems and potential problems. Now, I know that long nails might be a potential problem if we don't address it. So I'm going to put on my care plan that you're going to do hand and nail care twice a week on the residents to help prevent that problem from occurring. Good? Questions on that? No questions? Okay. All right, so let's learn washing rules. This is going to be on page 113. This banner is on page 112. If you're looking on page 112, you'll actually see that there are 5 skills that are washing skills on the state exam. And you most likely, it's not guaranteed, but you will most likely get a washing skill of some sort. Most likely. This falls under ADL skills. And remember, on the test, you get 1 ADL skill, 1 mobility skill, and 1 documentation skill. So since washing skills are ADL skills, there's a pretty high likelihood you're going to get 1. Washing skills are not hard. You guys all know how to wash something. Everybody has showered this month, I'm assuming, bathed in some way. Yeah. So the skill is not hard as long as you know the principles. Of course, we're going to follow the care plan. We're going to do the opening. Every skill starts with an opening. Every opening starts with a knock, right? We're going to evaluate if we need gloves. So let's stop there for a second. So you're going to be the patient at the test, right? And you are in pretty good shape. I don't see any wounds, rashes, sores, or incisions on her hand. She's holding on to all of her own body fluids like a champ. And if I'm near any personal skin for this skill, I've taken a totally wrong turn, right? This is a hand and nail care skill. So for the test, chances are you're not going to need gloves for this skill. Now, if we've got a patient with a big skin tear on their hand, does that change things? because that's open skin. If it's open skin, what do we need? Gloves. So good? You guys understand that? Okay. So we need supplies. So barrier rule obviously applies. We're going to be using linen, so we're not going to hold them up next to our uniform, and we're going to dispose of them properly. We're going to learn some washing rules. We're going to clean the basin the way we always do, and we'll do our closing. So this looks like a big skill because it's got a lot of principles, but you already know most of them. Okay. So let's get to the ones we don't know. All right. So if you're on page 113, this is what I'm going to be talking to you about. So you don't need to take any notes. Everything is there for you. But I need to explain to you why we do things a certain way. Now, one of our big principles with this skill is that basins are no soap zones. If I'm going to wash something, I'm not going to put soap directly in the basin. Now, a lot of you are going to want to do that. It makes sense, doesn't it? You know, if I want to wash, it's like I wash dishes. I fill a sink up with soapy water. I wash my dishes, right? So this is kind of ingrained in you. But we're not going to do it that way because at the sink, when you're washing dishes, you can turn the faucet on and rinse those dishes. What do you think would happen if you washed dishes and didn't rinse them?
Taking a bath before you take a shower.
Yeah, absolutely. You're going to leave soap and food particles, and rinsing's kind of important. Gets even worse than that when we're talking about patient skins. We're going to get there in just a minute. But we don't add soap to the basin. Instead of that, we're going to consider that basin as a no soap zone. Instead of that, we're going to take the washcloth and wring it out really well. We don't like drippy, wet washcloths anywhere. So we're going to wring the washcloth out really, really well, and we're going to apply soap to the washcloth. That washcloth, that soapy washcloth, will not go back in the basin. If you apply soap to it, once we're done using it, we set it aside. That way, we always have water in our basin ready for rinsing. Now, some of you are going to go, but wait, why can't I use two basins? One for soapy water, one for rinsey water. And you can, but every supply that you use, that patient gets charged for. And the basins are like $30-something on a medical bill. Yeah. So the best way for me to describe this, to explain this to you, because most people don't really think about the cost of healthcare. Imagine for a moment that you're going to go out to a restaurant and they have no menus. They seat you and they look at you and go, I know what I'm going to bring you. And yeah, I'm pretty sure I know what you're going to like. And I go to the kitchen and I get the food and I bring it out. So you've had no input on what you're going to order. And you also have no idea about the cost of the item that I'm bringing you.
You get an itemized bill.
And then at the end, you're going to get a bill that's just going to tell you, pay this. And it's not going to be itemized. It's just pay this.
It's a negotiation or something like that.
Yeah. So, but what if you don't have the money to pay that?
Or the knowledge.
That's a big deal, isn't it? Especially when I tell you, if you don't pay this bill, I'm going to ruin your credit. That's healthcare, guys. That is exactly what we do in healthcare. Patients have absolutely no say in the supplies that are used on them. They get a bill at the end that usually isn't itemized. It's just a bill. And if they don't pay it, we ruin their credit. Absolutely. In fact, here in Hernando County, they do take people to court for unpaid medical bills. They will garnish your paycheck and they will ruin your credit. Absolutely.
So that's like the same thing. If you're is it like the same thing when you're trying to like brush your teeth and all that? They'll have to pay for that as well.
Mm-hmm. Every supply that is used in that place gets billed.
Wow.
Can they bill that to the insurance?
Sure, if you have insurance is going to cover a portion of it. But most insurance is a copay and deductible plan. So deductible means before we even look at paying any of those bills, you're going to pony up some, right? So your deductible might be $1,500, might be $7,000. You know, different plans have different deductibles. So you're going to pay that before they ever kick in. That's out of your pocket right away. And then when they do kick in, they're only going to pay at a percentage, like maybe 70%. So you're still responsible for 30% of that bill. So this can add up pretty quickly, right? As CNAs, we really need to understand this because we're the ones that usually are going to the supply room and getting the supplies. So if we go get extra basins, our patients are going to be billed for that. If we think that we need a brand new toothbrush every time we brush their teeth, the patient is going to get billed for that. Right around $17 a toothbrush.
Can family bring in toothbrushes?
Absolutely.
From the dollar store we go.
Absolutely. Or one toothbrush. How many of you guys use a brand new toothbrush every time you brush your teeth at home? Yeah, absolutely, right? You guys are like, no way, that's stupid. Who would do that? That's ridiculous. Well, it's just as ridiculous in a clinical setting. But if you aren't aware of how the costs are structured in a clinical setting, you might make the mistake of throwing things away instead of cleaning them. Told you I'm plugged into a lot of CNA groups online. Well, one of the ones that I saw this weekend was somebody said, hey, do y'all wash your bedpans? How do you wash your bedpans? And almost everybody, there was like 70 comments. Almost everyone is like, girl, I throw that thing away every time. I'm not cleaning that. Okay, first, let's talk about the medical waste, right? Because that bedpan has to go somewhere. It doesn't just, disappear out of sight, out of mind. It's going to be in a landfill somewhere. And the second problem is the cost. That's expensive. So we've got to be a little bit smarter about this, right? And I kind of get the idea that maybe those CNAs weren't really taught about the costs of healthcare. I think it's important. Good? Okay. So if you think about how you bathe, it makes these washing rules a little bit easier to get through. So the way that we remember this is whatever you wash, you rinse. And whatever you rinse, you dry. Well, that just makes sense, right? When you're in the shower, you don't soap up and then just get out. What would happen if you left soap on your skin? Yeah, it dries the skin out. It can actually get crusty and leave a residue. So since we have to rinse the soap off, we need water in the basin to rinse with. Does that make sense? That's why we don't put soap in the basin. We put it on the washcloth and it works just fine. Works just fine. So don't add soap to the water in the basin. Keep your water clean for rinsing. To get water, you have to remember that your hands are clean, right? So we did our opening, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? I'm going to close your curtain for privacy and go wash my hands. Now, the first thing I get after washing my hands is a barrier. And then I go over and get all of my supplies. Now, there's lots of supplies for this skill, right? We'll go over those in a minute. A lot of supplies for this skill. So I'm going to go get all those supplies and put them on my table. If I forget one, it's not a big deal. Nobody is grading you on the supplies. There's no checkpoint said got the right amount of washcloths. No checkpoint at all. You're only graded on what you do with those supplies. That's it. You're graded on what you do with the supplies. So if you don't have enough washcloths, that means you can't do a step. So if you realize that, hey, halfway through, I need to go get something that I forgot, you can do that. That's fine. No problem. But if you've already touched your patient, are your hands clean or dirty? And you have to get into the clean supply cabinet. Do you think we're allowed to go into that clean supply cabinet with unclean hands. So what would you need to do? Wash your hands before you get your supplies. Make sense? So it's not about getting the right supplies. It's about understanding the infection control part of it. Okay? So please remember that your hands are clean. If you have to get water and your hands are clean, is that faucet clean? Uh-oh. So wait a minute. We've got clean hands and I've got an unclean faucet. How am I going to turn the water on? With a paper towel. Good? Make sense? A barrier. Very good. So we're going to go get our supplies. We'll pick up the basin, take it over to the sink. We're going to turn the paper towel on with water. It's Monday, guys. We're going to turn the water on with a paper towel. And then you want to check that water temperature with the inside of your wrist. So this is one of the most sensitive areas of our body because it doesn't have a lot of subcutaneous fat. We're going to talk about subcutaneous fat coming up here. Can't remember whether it's today or Wednesday, but we don't have a lot of subcutaneous fat here, which means that it's a pretty good indicator of how things actually feel, like it's true temperature. If I try to use this part of my arm, there's a lot of fat there that's insulating me from the true temperature. Okay. Now, subcutaneous fat kind of acts as a wetsuit. We'll talk about that a little bit more. But you're going to check the water with the inside of your wrist. It should feel just warm, not hot, not cold, just warm. Now, I am going to tell you that those evaluators will often stick their finger in that water to make sure it is truly appropriate. So don't skip this step. You've got to check the water. Make sure it's appropriate. It should feel warm. Not hot, not cold, just warm. But you're not the only one that checks it. Your patient has to check it as well. So let me explain to you why. If you look at this, this is kind of a cross section of the skin here. So when you're young, you have a nice, healthy dermal layer. So your skin is actually thick, lots of cells there. And then you've got a subcutaneous fat layer, which is kind of thick. And then you have muscle, which is also kind of thick. So you got lots of good, meaty layers here. But as you age, those layers start to shrink. So when you get into middle age, you can see that the skin layer is starting to compact. Skin gets thinner. The subcutaneous fat layer is smaller, and we even start to lose a little muscle mass. As we become elderly, all of those layers shrink even more. Why do we care? And your extremities, that layer of fat can be almost non-existent. Have you ever seen an older person's arm? It kind of looks like skin over bone. And you see these big veins kind of roping all the way up their arm. I mean, they're very, very visible. You can't see that on me. Can't see it on you. So what happens between our age and old age? Well, that layer of fat goes away. So that's why we can actually see the veins underneath. Make sense? Well, why do we care? What does that layer of fat do for us? Well, it actually acts as a wetsuit that you never take off. So our bodies run at right about 98.6 degrees, give or take a degree. Okay. That's hot. If you walked outside and it was 98.6 degrees out there, first thing you're going to say is, that's hot. Hot. 98 degrees. And yet, you sitting there are running at 98 degrees, right? So the principle here that you have to remember is that room temperature always wins. Always. If I take a pie out of the oven and it was cooking at 325 degrees, it'll be 325 degrees when I take it out of the oven. But if I set it on top of the stove and leave it for a couple hours and come back, will it still be 325 degrees? What happens to it?
Room temperature now.
It cools down, and it's going to cool down to a very specific point, room temperature. Room temperature always wins. If you take ice cream out of the freezer to go with that apple pie, it's cold. It's probably about between 0 and 15 degrees. Set that ice cream out on the counter for a couple hours. Does it stay cold?
It's a milkshake.
Yeah, it becomes a milkshake. It melts everywhere. It warms up to room temperature. So room temperature always wins. Got it? Doesn't matter whether you're starting with something cold or something hot. Room temperature will always win if left there long enough. This is an important consideration. I need you to really grasp this. So if room temperature always wins, doesn't matter whether it's hot or cold, room temperature always wins, and our body has to stay at 96 degrees, that must mean the room temperature is 98.6 degrees, right? Is this room temperature 98 degrees?
No.
No, because that would be
Abuse.
Totally uncomfortable, right? No, we don't like 98.6 degrees. We want it in the 70s. 70s is comfy for us. Some of you are a little higher 70s, some are a little lower 70s, but in the 70s is comfortable. So right now in this room, we are in the 70s. Your body is, what does room temperature always do? Win. That's a problem. Because room temperature right now is trying to equalize your temperature to the room temperature. It's trying to pull your temperature down. And unfortunately, you cannot live if your temperature gets below 95 degrees. Below 95 degrees is not hypothermia. Below 92 is dead. So if room temperature always wins and our body has to be at 98.6 degrees, there is an epic battle being raged right now. Got it? When you eat, that is the primary purpose of taking in calories. We all think it's, nutrition, and nutrition plays a part in it. We break down that food and we do stuff with it. But that's not the real reason. The real reason is that you have to burn calories as fuel to generate heat to keep us at 98.6 degrees. Okay? That's why you eat. To burn, that's why we call it burning calories. You're using it for fuel. Isn't that cool? Okay, so hold on to that. If you don't have a layer of fat under your skin, those calories that you're burning, that heat that you're generating is going to dissipate. So that means your body is going to have to work that much harder to keep producing heat, to keep you at that temperature. But because you've got this layer of fat all over your body, it acts as a wetsuit. And when your body burns those calories and creates heat, that fat layer keeps the heat where it's supposed to be. So your body doesn't have to work as hard. Good? Make sense? What do you think is going to happen if you lose that wetsuit?
Bottles are not going to go your way.
Okay, so yeah, your temperature is going to drop, right? So the normal temperature for older adults is often a little bit lower than it is for us because a lot of their heat is radiating away. Now, it also helps if you maintain a warmer environment because remember, room temperature always wins. You ever walked into grandma's house and gone, whoo, it's hot in here. Grandma, turn on the AC. And she's like, oh, no, I'm fine. Yeah, that's because if the room temperature is higher, their body doesn't have to work as hard. See how that works together? Pretty cool, right? So we need to understand that that wetsuit, once it's gone, we can't get it back, and it serves a very important purpose, but it doesn't just keep body temperature in, it also keeps outside temperature out. So have you ever seen an old person that says, hey, I just can't handle the weather up north anymore? It's too cold. I just can't tolerate it. Well, that's because when you, with a healthy subcutaneous fat cover, when you go outside and it's cold, you're insulated from a lot of that. If they don't have their wetsuit, they're not. So they're going to feel temperatures, outside temperatures, much more acutely. This is why we have snowbirds, because it's hard for them to acclimate to temperature extremes. So if they're up north in the summer, it's cooler. If they're down here in the winter, it's warmer. This is why snowbirds exist. And it's because they don't regulate their temperatures as effectively, because they don't have that layer of fat to hold the body heat in. Because room temperature always wins. Good? Makes sense? Okay. This is an important concept. It kind of seems a little bit nebulous, but it is an important concept. A couple years ago, we had several hurricanes go through, and it knocked out power to many nursing homes. And we actually had patient deaths because of the heat. So why would it affect a patient and not us? I mean, we're fine. You know, we can tolerate the heat. Why would it affect the patients and not us? Okay, immune systems, but they also, yeah, they don't have a wetsuit. So all of that heat is going to drive up their temperature. Does that make sense? So we now have a rule that every nursing home has to have an on-site generator. Yeah. Okay. So good? Makes sense? So just like infants they have lots of subcutaneous fat. Infants are pudgy little guys. They're so cute, right? But they don't have the nervous system to regulate their body temperature. So we have to really watch infants for temperature problems. But this happens at the other end of our lifespan as we get older. It's not because of the nervous system, it's because of our subcutaneous fat. So if we are going to use water and we check that water with the inside of our wrist, it may feel perfectly fine to us. Do you think your patient is going to have exactly the same perception of that water temperature if they don't have a wetsuit? No. So if we're going to check that water, we've got to make sure that we get the patient to check the water as well. That's going to be a very important checkpoint. Okay. So remember that subcutaneous fat keeps outside temperatures outside, inside temperatures inside. And when we lose that layer of fat, we don't have the regulation that we need. Okay. Good. So remember that your patient is going to check the water. I check it, patient checks it. I'll tell you a story about this. I was sitting at a nursing home and working on a care plan, working on some charting. And the shower room was about halfway down a hall off to my right. So there were 3 halls, so one straight ahead and one on each side, nurse's station. About halfway down the hall to my right, there's a shower room. And I am hearing blood-curdling screams. I mean, just screams. So I get up and go down there to find out what in the world is going on. You know, maybe the CNA slipped and the patient's trying to get our attention. I mean, what's happening here? And I open up the shower room and steam just starts billowing out. I mean, like my glass is all fogged up. I can't see anything. It's super hot. I walk in and I'm like, what is going on? And the patient is literally fighting the CNA, slapping at her, and the CNA is trying to bathe the patient. It was just like, hold up, stop, everybody stop, everybody stop. So I walk over and turn the water off because I need to find out what's happening here. And the CNA starts in immediately. She won't let me give her a shower. And the patient is just like beside her. It's too hot. It's too hot. It's too hot. And the CNA's arguing. It is not hot. I checked that water. It's fine. Patient's yelling, it's hot. It's hot. Patient's skin was bright red. And the CNA's like, it's fine. Very defensive. Okay, help isn't help if it doesn't help. If your patient is yelling that the water is hot, I don't care if you think it's okay. It's not okay for that patient. Help isn't help if it doesn't help, right? So the CNA had no understanding of why the patient would perceive water temperature differently than she would. Didn't understand that. I explained it to her. But when your patient says the water is too hot, don't argue with them. Change the water. Don't argue. I was just, why are you arguing? You are not being the one showered. So please be very careful with that. Sometimes we get so entrenched in what we want to do that we kind of forget why we're doing it. But we also have to understand that different people have different preferences. Me? Exactly.
That's insane.
Exactly. So me, I like my showers super hot. I mean, I want them flailing my skin off. I want hot, right? Some of you are like that. Some of you want your showers as hot as you can get it. Others are like, oh. Some of you like cool showers. It's refreshing. So even in this room, we have different preferences. There's also different times of the day that I like different temperatures. If I'm taking a shower first thing in the morning, I might want it hot. If I'm taking it last thing in the evening, I might want it cooler before I go lay down. You might be opposite of that. So we have to understand that people are different. We all have different preferences. And that's what this step is all about. Check the water temperature, but make sure that you've got that patient checking it as well. Good. So whatever we wash, we rinse. Whatever we rinse, we dry. That just makes sense. We all know this intuitively. And this is what skin looks like if we don't rinse it off. That's itchy and irritating and will usually end up in a rash. And it's just no good for anybody. That's not what we're going for here. I'm trying to figure out how to say this. When you get to the test, you're going to forget this. Because when you get to the test, you're focused on you in all reality, right? You are being tested. You're going to focus on you. You know to wash, rinse, and dry. I don't have to tell you that. You're all adults. You've been bathing yourselves for a while. You know the steps. But when you're doing it on somebody else over here, you will absolutely forget a step. You will forget to rinse or you will forget to dry because you're all in your own head. So the best thing for me to tell you to do is when you're doing this skill, actually say the steps. Whatever I wash, soap, I have to rinse. Bring the washcloth out, rinse. Whatever I rinse, I have to dry, right? So say the steps. If you do that, you won't forget it. I know it's super simple. I understand that. But when you're practicing, we'll start having practice time on Wednesday. When you're practicing, you'll realize that that will help you because you will forget. Okay. We don't have any practice time the first week and a half because you don't have enough skills under your belt to practice. I talk nonstop up until 1 o'clock or 1:03. Starting on Wednesday, we'll have a little bit of practice time in class. Next week, we'll have even more practice time. The following week, we'll have even more practice time. So as we go through the program, I talk less, you do more. Okay? But not today. I still have to preload you. Okay. Cold water is uncomfortable. Soapy water doesn't rinse. So we need to watch our basin if it starts to get cold or the water gets soapy. What do you think we should do? Yeah, change the water out. Absolutely. Absolutely. Okay, we're gonna get to this one. I know I've got it blanked out. We're gonna get to that one a little bit later on in the program, but we want to make sure that our surfaces stay dry. So we've got a barrier on the table, but we definitely want to watch what we're doing here. We don't want drippy wet washcloths. We want to protect the bed if we're working on the bed. Make sure that the water doesn't spill onto the floor. Just take a look around. Okay, dry surfaces must remain dry. And then anytime we're going to use lotion, we always warm it up first and then wipe it off. It's kind of important. Cold lotion, no fun. No fun. Don't just squirt cold lotion on somebody. The best way to warm lotion is put it in your hands and warm it up by rubbing your hands together. It's the best way to warm lotion. We used to just throw the bottle in the basin and let it kind of bob around, but that water's just warm. It's not hot. And all it's going to do is make the outside edges of the lotion a little bit warm. But when we squeeze a lotion out, it doesn't come from the outside. It comes from the middle. That heat isn't going to penetrate. So don't rely on your water to get your lotion warm enough for comfort. Best way to do it, rub your hands. And then once we put lotion on, we always wipe off the excess with a towel. You never want to leave lotion on the surface of the skin. Your skin is only going to absorb so much. Whatever's left is going to make the hands slippery. Can you imagine doing hand and nail care on somebody and then they go drink a cup of hot coffee? They got lotion on their hands. What's that going to do? Yeah. All right, good.
So if you use too much lotion, what should you use? Like a towel to dry
Yep.
some of it off?
Absolutely. Whether you use a little lotion or a lot of lotion doesn't matter because we're always going to wipe off the excess anyway. And we'll do it with a towel. All right, so our skill-specific steps here. So this tells us how to do this particular skill. So these steps aren't going to be found anywhere else. We want to soak the hand in the water. We're going to wash, rinse, and dry. Clean under the nails with the beveled end of the orange stick. So when you have an orange stick, some of you call these manicure sticks, it has like a slanted end. That's what we're going to use to clean underneath each nail. When you clean under a nail, don't import that to another nail. So we're going to clean and then wipe it off on a towel before we move to the next nail. Okay. You want to make sure that the hand is supported on a towel. We're going to warm the lotion up and wipe off the excess. Anytime you move a patient's arm, make sure that arm is supported. You know, don't just lift it and kind of flop it places. You want to support the arm. Be nice. Okay. All right, so let me go ahead and show you this video. Caitlin, if you can hear me. Oh, that's right. Never mind. I got to start the video. I forgot. Okay, give me a second. Hold on, guys. My computer is completely dead.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about you?
Wonderful. I need to do hand and nail care on one hand. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, and then I'll gather my supplies.
Okay.
Okay, we're going to start with the barrier. So I'll place a barrier on the table, and that will give me a place to set your clean supplies. And then I'm going to gather a basin, soap, and lotion. An orange stick and emery board. Two washcloths and a towel. I'm going to go get some water in the basin.
Okay.
Okay, Mr. Jones, would you like to check the water temperature, make
Yes,
sure it's
please.
okay?
It's
Is
great.
it good?
Yes.
Okay, you can submerge your hand in there if you'd like,
Okay.
and I'll bring that tray a little bit closer to you.
Thank you.
Is that comfortable?
Yeah.
I'm going to place the washcloths in here, and we'll wet one of the washcloths and use it to get your hand wet. Now I'm going to place your hand over here on the towel. Apply soap to the washcloth. And now I'm going to wash all surfaces of your hand, including in between the fingers, in this area between the thumb and the forefinger. We're going to turn your hand over now and wash the palm of your hand. Now we're going to place your hand back in the basin to rinse. Okay, I'm going to bring your hand over here to dry. I'm going to dry between the fingers. And then I'm going to turn your hand over and dry the palm of the hand as well. Okay. Now we'll take the orange stick and I'm going to clean under each nail. Just cleaning the edge. Does that hurt?
No.
Very good. We'll wipe the orange stick on the towel in between each finger. And now I'm going to file any rough edges. So I'll file from the outer edge to the middle, checking each nail for any rough edges. And now we can apply lotion. So I'll get a little lotion, warm it up in my hands, and apply it to all surfaces of your hand. Does that feel good?
Yes.
You only warmed it up with your fingertips. Could you use your hand?
Doesn't matter. Just warm. Okay. Is any Now we'll friction wipe will off the warm it. lotion. Okay. How's that?
Great.
Wonderful. I'm going to place my soiled linens in dirty linen container and then clean up my workspace. I'll be right back.
Okay.
Okay, on the way, we'll pick up the soap and the lotion and place them in the basin. We'll use the paper towel to open the drawer, place the basin in. These items will get thrown away. Mr. Jones, are you comfortable?
Yes, ma'am.
Can I offer you a magazine?
No, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is right there. Please use it to call me if you have a need. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
He was just gonna sit there.
Yeah, he's a robot, man.
Yeah, I was gonna say, like, I would have been like, all right, well, I'm gonna go lay down now. He's like, I'm just gonna.
Yep, nope. He makes a great patient because he doesn't make it about him.
Okay.
Yep, he allows the skill to kind of
And
take
you
center
didn't
stage.
disinfect the basin because it's his. It's his.
It's his. Yep. For the test, we're not going to disinfect anything. Rinse it, dry it, and store it. So any questions on that one, on hand and nail care? That's the first big skill that we've learned.
Is there anything that changed between then and now?
No, this is hand and nail care. I don't see it ever changing. All right. Hmm?
No, it just depends on their condition.
It depends on your patient. If your patient has a brand new kitty cat and has a huge scratch on one hand, I would absolutely wear gloves.
I'm glad I'm taking this class. And the only reason I say that is because, like, I know I won't specify where, but, like, I remember they were going to have me try to clean the patient's nails, and I was actually removing nail polish, too. I didn't know what I was doing, and they were not guiding me through it. So they said, you can figure it out. It's not hard. Just do it as if it was your own nail. I don't take nail polish off. I don't know. You know what I did? I filled the whole basin with nail polish.
Remover?
Mm-hmm.
Oh.
And I had them dip their fingernails in it, and I removed it. And, like, no one told me nothing. You just got to figure it out yourself. Mm-hmm. I had them wash your hands afterwards.
Well, yeah,
but, like,
that's not training.
yeah, that's what I'm saying.
So where should I not apply it?
Yeah.
That's how it is. Some places are like that.
Yeah. So let's talk about that real quick. Let's talk about nail polish. Some places that you work, your patients will have nail polish on their hands. You are allowed to take it off, if somebody tells you to, care plan. But you'd want to find out the method that they want to use. Gel polish has to be removed completely different from regular nail polish. So we kind of need to know what we're working with here. But in general, for regular nail polish, you probably don't want to soak the nails. Perfectly acceptable for you to do so, but acetone is very drying. Okay, so if we're soaking the hands in acetone, which is nail polish remover, it can dry out the skin of the hands. And we already have, as an elderly person, thin skin, less subcutaneous fat. But the skin is already dry because we don't produce as many oils. So if we have thin, dry skin and we're soaking in an acetone, we could end up with skin tears or skin fissures or other issues. So as the nurse, I would probably tell you, hey, I want you to take the nail polish off of that patient, but instead of soaking their hands, just put nail polish on or nail polish remover on a pad, like a 2x2, and use that to get the nail polish off. That will help reduce the amount of drying. Make sense? Yeah, they shouldn't have just said, yeah, go figure it out. It's not that hard.
Pretty wild.
Yeah, that's not training.
That's a setup.
Yeah, exactly. Exactly. All right. Any other questions? Any other questions? No? Let's go ahead and take your break. Come back at 1:45.
Is that pizza place open?
I don't know. I don't know what time they open, actually.
Because I never eat breakfast before I come here.
Someone
and I'm
find out.
hungry. Yeah.
Pizza party.
Yeah.
Yeah, 'cause we're just ready.
Was the pizza place open?
Yeah, I opened that right now.
Oh, it opened?
Break.
Okay.
We're doing the pulse skill
Mm-hmm.
for the testing because we have 2 evaluators. How would we transition into the second one?
So they'll take care of that for you. They're going to tell you, you need to count with the second evaluator now. So they'll just switch places. One of them will come to the bed. They will let you write down the first reading though. That way you're not trying to remember one while you're counting another, because that can be very difficult.
Sometimes doing it right then and there with the cup can be difficult to catch the first number. You forget the first number, but you remember the last one.
I think you're talking about blood pressure, right?
Yeah.
Yeah, that does happen too.
Class already started?
Come on in. You're good.
You sure?
Yeah, come on in.
I had to order a whole pizza because they don't do slices.
Ah.
So if anyone else wants to get freaky with pineapple.
No problem at all. Smells delicious. Now I'm going to have pizza for lunch.
Well, I got extra slices.
Feel free. You're fine. All right. So let's get into making an occupied bed. This is going to be on page 141 of your book. And if you look at this page, you'll see all of the principles involved in this particular skill. So most of these are things we already know. We know skill rules. We follow the care plan. We know to do the opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do whatever. Is that okay? Close curtain, wash hands. We know to evaluate whether we need gloves. We know to use a barrier because we're using supplies. Our patient's going to be uncovered, so we need a privacy blanket. We already know that. We've gone over linen rules. We don't hold linens up against our uniform. We use it or we lose it, and don't put anything on the floor. And we know the closing. So what we need to learn for this skill is scoot and roll and skill specific. So scoot and roll is a totally new concept for you. It's not something that we've covered yet. So let's get into this. If you go to page 142, you'll see our care plan at the top of the page, supplies at the bottom, and step-by-step instructions. And when we learned linen rules, there were 2 that I kept grayed out that I told you we would be getting to later. Well, now is later. We're going to get to those as well. This is one of the big principles. Clean rolls toward me, dirty rolls away. We're going to get to that in just a second. But when you're looking at these supplies at the bottom, I actually put pictures in. This is new for this edition. Before they were just the words. So now you can kind of see what the supplies look like. There aren't a lot of supplies for this, but you'll see as we start to go through the program, we get more and more and more supplies. You do need to learn those supplies. This one's kind of easy. What do you need to change sheets? I mean, it kind of solves itself, right? You need sheets. Yeah, your patient's uncovered or undressed, so you'll need a blanket. And if they're leaky at all, you're going to need some gloves, right? So for the test, you're doing this on a person who is fully clothed. Remember, another testing student, fully clothed. You're not going to touch any of their personal skin. So for the test, gloves are not required. You can wear them if you want to, but it does make the skill a lot harder when you're trying to work with gloves. So let's get to those 2 principles on linen rules that we did not go over before now. So we've already learned that linens must not touch your uniform, that you have to have clean hands to get your linens, that we're not going to snap or shake them, and that unused items must be discarded. We know those already. So let's go over these 2. Clean rolls toward you, dirty rolls away. So what this means is, ideally, in a perfect world, if I need to change patient sheets, I'm going to get them out of bed. In a perfect world, I like to make beds when there's nobody in them. It's easier, quicker, less stress on the patient, less stress on me. So if my patient is out of bed having a test done, that's an awesome time to change the sheets. If my patient is out of bed in the shower room, I should think about changing the sheets. Basically, if the bed is empty and I'm walking by it, I automatically think, do those sheets need to be changed? Because I can change an empty bed in less than 2 minutes. A full bed, one with somebody in it, is going to take me about 11. That's a huge time savings, right? Make sense? But when you're changing the bed and somebody's in it, it does increase the complexity just a little bit. It's not overly complex, but a little bit. So let me explain to you how this works. So we have a sheet here on our bed, and we have a patient on our sheet. I'm going to go to the side of the bed. Okay. So I've got a patient laying on a sheet. So we remember this process by clean rolls toward me, dirty rolls away. So the sheet that the patient is laying on is dirty. That's the one I'm trying to change out. So dirty rolls away from me. So when I roll this sheet away from me, I'm trapping all the contamination inside the sheet. So what's facing up here is the underside, the part that didn't actually touch the patient. Good? Make sense? Now, clean rolls toward me. So I'm going to take the new sheet, stretch it out, and I'm going to roll the clean one toward me. And I'm going to tuck it up underneath that dirty one. So the only thing that has touched here is the underside of the dirty and the underside of the clean. Make sense? Got it? Don't get too wrapped up in this. The patient is still in the bed. The thing that made the sheet dirty is still there. You're not going to get sterile, guys. You're not even going to get like overly clean. We're just trying to get cleaner. Ideally, no patient in the bed. We can do a really good job then. But when the patient is still in the bed, that becomes more problematic. You're not going to get it as clean. Does that make sense? So a lot of people get all wrapped up in this and they think, well, what about the pillowcase? The pillowcase is dirty and now it's on the clean sheet. Well, so is the patient. Nobody cares. Okay. Good. Makes sense? Right. Yeah. Cleaner. We're going for the not est. Good. Okay. So clean rolls toward me, dirty rolls away, and that way the undersides are all that's touching. Now, excuse me. Now, if I have a dirty sheet that I have rolled toward the patient to expose the mattress, and I'm going to put the clean sheet on and roll it toward me. If that mattress is wet, well, I don't want to put a clean sheet on that wet. I've got to clean the mattress. So what I would do is I would roll the dirty sheet toward the patient and tuck it up under their hip so they're kind of holding it. And I've got a bare mattress here. I would take a cloth with a disinfectant and wipe that bare mattress down before I put the clean sheet on and rolled it toward me.
Is the mattress usually not absorbent in that scenario?
All healthcare mattresses are waterproof. Yeah, because healthcare patients tend to leak something at some point.
I was going to say, because in care facilities, I've noticed that that's usually like live-in residence homes. You know,
So if you're in an assisted living facility, it's probably just going to be a mattress. But in an assisted living facility, we shouldn't be making occupied beds. Okay. Does that make sense? But in a clinical setting, the beds are going to be similar to this. The mattresses. So if I take the sheet off here, you can see that the mattress is waterproof. That one is too. So all acute care mattresses are going to be more like this. Okay. Now, if the bed is wet, that means that whatever the patient leaked went through the sheet. So when I roll the sheet up and put it underneath the patient, the underside of it is going to be wet. If I take this and roll it and try to shove it, I'm going to contaminate the new sheet, right? And we're not looking for sterile, but do we really want to make the sheet wet before they've even used it? So what I could do, because we never want our patient laying on a bare mattress. I don't just want to take that sheet all the way off. That's kind of gross. We don't want a patient laying on a bare mattress. So instead, what I would do is take a Chucks. Remember those Chucks? I would roll the dirty one toward the patient, tuck it up under them, take a Chucks, and just cover the wet with the Chucks. Remember, Chucks are waterproof, right? So if I took my Chucks, and I'm just using this to kind of give you a smaller view here. But if I rolled a dirty sheet and then took the Chucks and covered the sheet with the Chucks and tucked that under, now nothing can get out. Now I can tuck my clean under there and I don't have transfer. Good? Make sense? Okay, so Chucks we use for a lot of things. A lot of things.
Anything that needs a barrier.
Anything that needs a barrier because it's absorbent and waterproof. So we can use it for a lot of options. But remember, clean rolls toward me, dirty rolls away. So you can see that here. I gave you a graphic, but the graphic doesn't, I need to work on this graphic a little with some shadows to make it make a little bit more sense. But clean rolls toward me, dirty rolls away. We don't want our patient on a bare mattress. So we've got to make sure that we take that clean sheet and tuck it up underneath the dirty one so that our patient, when they roll back over, is not on a bare mattress. Okay. All right, the other one is that we don't want clean or dirty linens to touch floor. So basically nothing on the floor. Once you use something, or if you're taking a soiled something off of the bed, you don't want to just throw it on the floor like we do at home. When I change my sheets at home, I take the sheets off the bed and they go on the floor until I get the whole bed stripped, and then I bundle it all up, take it to the laundry room and do my laundry. We don't do that in a clinical setting because of pathogens. We don't want those pathogens on the floor. So if we can't throw this stuff on the floor, we got to know where to put it. And that's what we're going to talk about now. So you definitely don't want anything clean on the floor either. So just remember, nothing goes on the floor. Not clean, not dirty, nothing on the floor. In most cases, we're going to use a hamper like this. Now, these hampers are not in the patient's room, though. They're usually in the hallway, or they may even be in a totally different room called a soiled utility room. We're going to get to that in a second. If that hamper is too far away, it doesn't do us any good. If it's down the hallway, I'm not going to take a sheet off the bed, leave my patient, go down the hallway to try to find a hamper, put it in the hamper, come back to my patient. That's too much work, too much time. That's not effective. So we have to have another option. If I can't throw it on the floor, where do I put it? Because we don't like keeping dirty things in the patient's room. The hamper won't be in there. In most places, we have a bag, and it's actually going to be stamped soiled linens. It's usually light blue in color. If you go get this bag and open it up, you can put the bag on the floor. Linens go in the bag. Just no linens directly on the floor. These bags are pretty cool. They're more than just a regular bag. They look just like a regular bag that's stamped soiled linens. But are you guys familiar with Tide Pods? You know, the little things you throw in the, not to eat. Don't eat those. that you throw in the washer, right? Well, these bags, we've been using these for years and years and years and years in clinical settings. They are the original Tide Pods. The soap, the commercial soap, is actually part of the bag. So when we strip beds and we put sheets in that bag, the whole bag goes in the washing machine. The whole thing, and it dissolves in hot water, and it's the cleaning chemical, the laundry soap. So that's cool. The reason that we did that is because, especially in acute care like hospitals, a lot of times needles will unfortunately get kind of left in the bed. People don't take, they're not. Anyway, it does happen. But you also can have bandages and, all kinds of things. Our laundry people don't want to get accidentally stuck, or they don't want their hands full of bloody bandages. They're not prepared for that. They're laundry people, not frontline medical people. So in order to try to keep our laundry people safe, this system was implemented. So it's important for you to know this, because nobody is going to be going through that laundry looking for hearing aids, dentures, cell phones, earrings, watches. Everything that's in that bed is going into the washer. There is no secondary check system. So when you're bundling up sheets to put in a bag, you should be looking for any foreign items. Does that make sense?
How would you accidentally leave a needle?
Oh, it happens all the time. All the time. Yeah.
Because I'm trying to understand, like, if a patient's there and he rolls over and there's a needle, I don't know, that just don't seem safe.
No, it's not. And nurses should use more diligence. But in very fast-paced situations, very common. Very common. Okay. So look. Yeah, and unfortunately, about 20 years ago, needle stick injuries were very high on laundry services. Yeah. So that's why this system got implemented. And then, we all said, well, we want something we can just throw in the washer. I don't want to measure out soap. So they came out with a commercial version of this. Now, if the hamper is down the hallway and you can't get to it, if there are no soiled linen bags that you can access quickly and you have to change the sheets, remember, we can't put them on the floor. So option number 3 would be to put a chucks on the floor, and then your sheet can go on the chucks. Okay. Again, a barrier. Good. But no sheets directly on the floor, clean or dirty. No sheets directly on the floor. Any questions on that?
Do you want to evaluate your room before you grab the linen?
You would, yeah. That would be ideal. Usually if I'm changing sheets and I know I'm changing sheets, I always just grab a bag. I know I'm going to need one, so I'll just grab a bag. Yeah. In your trash cans, like they have trash cans like this, in every patient area, right? They have trash cans. If you take that bag out, underneath the bag are more bags. So clean bags. Should be. Yeah. If my housekeeper is on point, I should have some clean bags in the bottom of that. So that's the first place. If I am in a hurry, that's the first thing I look for. Because I've got the trash can right there, I'll just grab a clean bag out from under the open bag, and I use that until I can get my soiled linen bags. So yeah, when you realize there is always a clean bag in that room, it's just hidden, you'll figure out a million uses for it. So that's one of my go-tos. So everybody good with this? Luckily for you, you need to know this. But luckily for you, during the test, there will be a laundry basket right at the foot of the bed or beside the bed. So you're not going to have to go walk anywhere. You're not going to have to go find a bag. You're not going to put chucks on the floor. You're just going to use the basket. Okay. Some testing centers have the laundry cart, like what I have there. Some use a laundry basket. whatever they have. Remember, I told you on day one that when they bring you into the testing center, they orient you. That's one of the things that they're going to show you. All dirty linens go here. Okay. Good. Questions? All right. So every unit has, when we're talking acute care, okay, so hospitals, rehabs, nursing homes for the most part, will have a special room called soiled utility. If it's dirty, it goes in this room. Nothing clean is allowed in this room, ever. So if you're going to get your linens and you've got a handful of linens, don't go into this room to get your bag with your linens in your hand. Nothing clean goes in this room. Just like when you're going into a clean utility room, you can't have anything soiled. Make sense? So you got to pay attention to that. Usually the soiled linen bags will be kept in the clean utility room because you're getting your linens and the bags are clean. But once we fill them, they would then go into the soiled utility room. Good. Questions on this? Okay. Remember, nothing clean can go here. Nothing dirty goes in clean. That could be a test question. And we already know this. Linens, use it or lose it. Right? You either have to use it or discard it. So let's learn a new principle. So let's look at the back wall for just a second and go over what we already know. We know skill rules. We follow the care plan. We know how to do the opening, knock, knock, knock. We know you use a barrier anytime we have supplies. And we've learned when to evaluate gloves. If our patient's uncovered or undressed, we're going to use a privacy blanket. We already know all of our linen rules now. And we just learned how to wash a patient. We know how to clean our basins and we know our closing. So if you're keeping track, there's only 2 left to learn. Scoot and roll and shoe rules. You guys remember on the first day I told you by the end of the second week, you would know everything on that back wall and it wouldn't be hard work? Look how far you've come. Okay. So this is our second to last principle that we're going to learn. There's only one more to go after this, and we'll get to that Wednesday. So this one's pretty short. There's only 4 parts to this, but it's probably one of the most important principles that we're going to learn. Now, all of them are important. I spend a lot of time on the principles because you're going to use them in many, many skills moving forward. But none of that matters if your patient is unsafe. I don't care how well you wash somebody if they're unsafe. I don't care how much you protected their privacy if they fall on the floor, right? So all of the rest of these things don't really matter if this isn't addressed. So this really becomes one of the most important principles that we're going to go over. And it's not counterintuitive, or it's not intuitive. The things that you are thinking, I've got to kind of break down, just like I did with gloves. Okay. So side rails. When we're working in healthcare, you're going to hear a lot about side rails. It used to be a million years ago when I first started this, that we put side rails up on every bed when we walked away from it. If you weren't at the bedside, you had to put the side rails up. And that was all in the name of safety. We don't want our patients rolling out of bed. So how many of you guys actually sleep in a bed? You think you got it down pretty well? Sometimes? We're going to get into that sometimes because I can guarantee I know what you're referring to, and we're going to talk about that. All right.
My brother will be sideways
So how long have you been sleeping in a bed? How long have you been sleeping in a bed?
About 20 years.
Okay. So you probably didn't start out in a bed, though. You probably started out in a crib. So for about the first year and a half of your life, right, you're in a confined space. You are in a crib. And mom does that because she wants to keep you safe. You don't know any better. You'll roll right off of that bed if she puts you in a bed. We need to confine you and keep you safe. So we tend to think about something like this as keeping patients safe because that's our experience, right? If we have somebody that could roll that doesn't know any better, we don't want them on the floor, so we do this. The problem is that nobody goes beyond this and thinks it through, okay? That sounds very logical, but at about a year to a year and a half old, what do children do? Do they just keep laying in the crib? They climb out. That's right. They climb out. Now, why are they climbing out? What's that? Because they want to get up. Yeah, they don't want to be confined. They have the ability to get up and over. Now, is that crib safe now? No, it's actually much more dangerous because when the child starts to climb, if they fall, they're falling from a much higher height. Good? Okay, so the crib worked, but only until that child gained some independence. Then mom takes you out of the crib and probably puts you in one of those little tiny low beds, right? Toddler bed. And if mom liked you, she probably put something soft on the floor. That way, when you fell, it wouldn't hurt too bad. And this is when you learn how to sleep in that mattress that we are all sleeping in now, right? You learn how to sleep in a bed. About a year and a half, 18 to 36 months, we develop what's called spatial awareness. Now, what this means is that your body is able to position itself safely in the space you have to work with. So all of you are sitting in chairs right now without arms on them, right? There's no arms. So how are you safely staying in that chair without something to keep you there? Balance. Okay. So you've learned over time how to position. You're not like super close to the edge. You're not leaning over. Your body has learned how to position yourself safely within the space that you have to work with. Guys, this is developed somewhere between a year and a half to 3 years old. And it serves us throughout our entire life. Now, the thing about spatial awareness is it's a little teeny tiny part of the brain that never shuts off. Always on, except for two very specific times that I'm going to talk about in a minute. Always on. So when you go to bed at night and you swing your legs in and you lay down and you close your eyes, drift off, your body knows where it's at in that bed. That little piece of your brain is still awake. So even when you toss and you turn, you don't fall out of bed usually because your body knows the space it has to work with. And it's not based on the fact that you've been in that bed for a long time, because you probably go to other people's houses and stay, or hotels or whatever, and you're able to sleep in strange beds and still not fall out because that little piece of your brain is always on. It's also not limited to space. Beds are big. Have you ever napped on the couch? Your brain, again, knows the space you have to work with. So just because I put a patient in a hospital bed does not mean that automatically they're going to roll out. We don't need side rails to keep a patient safely in the bed unless there's another reason. It shouldn't just be routine. Because just like that 1.5-year-old, if I want to get out of bed, you think those side rails are going to stop me? So if I do try to get out of bed, the risk of injury is way higher. Side rails cannot be used to ensure safety. In fact, they're probably less safe. So everybody got that? Okay. I know a lot of you have other ideas about side rails, but they're wrong. And we've got to confront that so that we can learn the right way to do this. Now, this has all changed in my career. At the beginning of my career, we put side rails up for everything, and that was the industry norm. But we found that our patients were getting injured at a much higher rate because we put an obstacle in their way. Good? Okay, so sometimes we think we help, but it's not as much help as we think. Okay? So remember that side rails are a restraint. Anything that keeps our patient from getting out of bed is called a restraint. Now, you don't have the right to do that. We're going to get into that in just a second. But you don't need them to keep your patient safe. You simply don't need side rails in most cases. So let me get a volunteer. Let me turn that camera a little bit. I need a volunteer, somebody to come lay down on their back in this bed, please. Absolutely. Okay, just make yourself comfortable.
How long is that bed?
Let me get you to lift your head. You don't look comfy. There we go. All right. So I asked her to lay on her back in the bed. It was very specific in what I asked, and she complied. But where is she in that bed? Did I tell her to do that? She knows she's not going to be there very long. It would make more sense for her to be on the edge. But she put herself in the middle. Why do you think she did that? That's right. I didn't have to tell her to do that because her body feels safest in the middle. Your patients also have this ability. Okay. Can you turn so that you're facing that wall for me? Thank you. Just make yourself comfy. Now, she did not roll. She is still in the middle of the bed, just facing a different direction. She did not roll. Why didn't she roll? She'd be on the edge, and her brain says that is unsafe. Danger, danger, Will Robinson, danger, right? So her body didn't roll, it shifted. You guys do this without even thinking about it. You probably weren't even aware you did this. Your patients also have the ability to keep themselves safe by doing the same thing. Okay. Now, if they can't, that's when we are going to have to do this for them. So if I want my patient in the middle of the bed after the turn, I'm going to scoot their whole body toward me first and then roll them so that after the roll, they're in the middle of the bed.
So is there any kind of sicknesses like, I don't know,
Thank you. You can
flu
go
or
ahead and have a
something
seat.
that might shut off that spatial awareness?
Okay, so I told you that this works except for two very specific times, right? There's two things that affect this very specifically. One of those things is certain medications. Have you guys ever seen the label on a medication bottle that says may cause dizziness, caution, don't operate heavy machinery, right? So those medications are affecting spatial awareness. But there's something else it does too, alcohol. This is why you can start your evening on a bar stool and be just fine. And after a couple, that bar stool gets a little trickier to navigate, right? So alcohol can affect spatial awareness along with some medications. There's also some diseases that can affect this as well. But as the RN, I go in and I do a head-to-toe assessment. I'm looking for real problems and potential problems. This is a potential problem. I'm going to look at their medications. I'm going to look at their diseases. I'm going to look at their conditions. And I'm going to decide whether this patient has a spatial awareness problem or not. If they do, I'm going to put things in place to help protect them. If they don't, we don't need anything special. Patient comes with that built in on board. Good. But if we do have to turn our patient, we're going to scoot them toward us first and then turn them away from us so that they remain in the middle of the bed. So that's what we're going to talk about in just a second. So side rails are dangerous. Before we stopped using side rails routinely, they killed about 2,000 people a year. And that's because if this person wants to get out of bed, they have to go through this little tiny gap. And it's very easy for them to get entrapped between the side rail and the mattress. And it'll absolutely kill them. Absolutely. So we have to be really careful with that. Side rails increase the risk of injury, but there's something else with side rails that most people don't really even think about. We use side rails because a patient is weak. That's like the number one thing. They're a fall risk. I hate that term. Everybody is a fall risk. Everybody is a fall risk, especially if they have a condition or medications. Everybody is a fall risk. Bless you. The real problem here is that if you have somebody who is unsteady on their feet, we call it fall risk, but if they're unsteady on their feet or they lack strength or stamina, if you try to keep them safe by putting them in bed and putting side rails up to keep them in bed because you don't want them to fall, that does nothing to improve their strength, stamina, or coordination. It actually makes it worse because we're confining them to bed. You take an elderly person, put them in bed for 3 days straight and don't get them up, you can make them bedbound for the rest of their life. You can actually rob them of their mobility. That's horrible. If you've got somebody who's living alone and they're having a blood pressure issue, they go to the hospital, we stick them in a bed and we don't let them up for 3 days, they may not be able to go home because they may not be able to walk. We should never do that to our patients. That's horrible. So putting somebody in bed and putting the side rails up does more harm than good most of the time. People need activity to keep their respiratory system in good order, to keep their intestines moving, to keep their muscles strong, to keep their joints mobile, to keep their brain functioning. Activity is essential. And yet in clinical care, we often, because it's easier on us to warehouse our patients in bed, we totally disregard all that. And we can seriously mess patients up for the rest of their lives. So remember, I said this is one of the most important principles. Immobility, especially forced immobility, is absolutely detrimental to our patients. Make sense? So that kind of challenges some things that you may think you know about side rails. The other problem with side rails, with forced immobility, okay? So if you put me in this bed and you put the side rails up, because I'm a little unsteady on my feet, I got a bad knee right now, right? You put the side rails up. You don't want me walking on my own because if I fall, that's paperwork. So you put me in the bed, put the side rails up. I'm going to have to pee. At some point, I'm going to have to pee. So I hit that call light and I wait and I wait and I wait. And I'm a good patient. I'm waiting. But man, I really got to go. They're pumping IV fluids in me. And what goes in must come out. So I hit that call light again. Got to go. Let's go. Nobody comes. Nobody comes. We'll get to you shortly. Dude, I can't wait anymore. I got to go. So I have two choices. That's it. I'm down to two choices. I either pee my bed or I try to get around the side rails. Remember, I got a bad knee. going around those side rails, probably not a good idea. I'm probably going to get injured. But that's a heck of a lot more attractive than peeing the bed. Which option do you think I'm going to choose? Yeah, absolutely. That's a dignity issue. Absolutely. So when you put those side rails up, you better be absolutely positive that you have the ability to answer those call lights quickly. And you better be checking on these patients often. Are you okay? Do you need anything? Is there anything I can do for you? This comes with a high rate of failure. Okay, does that make sense? All we think of it from the healthcare standpoint is, oh, we don't want you walking because you might fall. You're hurting your patients in a million different ways, all because you don't want to do paperwork. That doesn't seem fair to me, right? All right, so let's talk about the positioning rails and side rails. So if you look at this, I know you guys, let me turn this. I got to get the follow me system. Yeah. Okay, so this at the top of the bed is a positioning rail. This is what you see here on the screen. So right here, a positioning rail, okay, top of the bed. This rail is not a side rail. This does not impact the patient's ability to get out of bed. Their legs are going to swing out just fine. This helps the patient turn in bed. It's called a positioning rail. These are absolutely legal and allowed. Can I help you? If you go right next door, they'll be happy to help you. You're fine. So if you put the top rail up, that's a positioning rail, perfectly legal. We can use these, no problem. It's when I put this one up that it becomes a side rail. So most facilities won't even have this on the bed. They're not even there. If we get an order for side rails from a doctor, we have to call maintenance to come put them on the bed because they don't even exist. They're not even there because we can't trust you guys, especially nights and weekends when administration isn't around. Yeah, they'll do this all day to keep their patients in the bed so they don't have to work as hard. We can't trust you. So side rails, usually not even on the bed. If we get an order, then we have to have them installed in most cases. But most places aren't using side rails anymore. We use sitters. A sitter is somebody just like you who is in a chair at the side of the bed, a real live person. So instead of side rails, we have a body that can help the patient with whatever it is they need help with to make them safer. Okay? And anybody can be a sitter. Now,
How much they pay?
they're minimum wage. It is a minimum wage job, no skill required here, right? So, but you'll see these on job descriptions as patient safety attendants. Some places will call them sitters, but most places call them patient safety attendants. And our local hospitals are hiring for patient safety attendants. It's a great way to get into, if the hospital is where you want to go, it's a great way to get into the hospital. And then once you get your certification, you already know the nurse managers, you already are familiar with the staff. You can transition into that CNA role. It's often easier to get into the hospital going that route.
The same thing is, I've heard it called like the 11th hour.
I haven't heard of that one.
What?
No.
I heard the one I in reference to that, he was like a volunteer, but it was with the hospice.
Oh, it's like
Oh, okay.
it's
Okay.
like the
So
12th man.
yeah.
Team.
Yeah.
Okay.
So what you're talking about is more of a companion at the end of life so that no one dies alone.
Yeah. That's what
Yeah. Yeah. And I believe in that. I don't believe anybody should die alone,
I
you
knew
know.
someone that used to do that. They would sit with people that didn't have anybody.
Right. And that's a volunteer position, and that's specifically for hospice. This is a paid position through the hospital. Okay, good. Questions on that? Questions on that? Okay. All right. Remember, half rails are not side rails. Now, in a long-term care facility, your side rails aren't going to look like what you see on the bed. Long-term care facilities, you'll have these long rails that go the entire length of the bed. So it's a little bit different style of side rail. And it is really, really, really hard. There we go. It is really, really, really hard to get an order for side rails. So let's say that as the RN, I've got a patient that I am concerned about falls. I need an order for side rails. I have to get that from the doctor. So I got to call up the doctor and say, hey, doc, concerned about my patient, think they're going to fall. I need an order for side rails. Now, if that doctor gives me that order, that doctor has to come in and physically assess this patient themselves within 4 hours, or that order expires. That's a big deal. You try to call a doc at 11 p.m. to get an order for side rails, and they have to physically come in within 4 hours, you're not getting that order. Not going to get it. They'll say, figure something out. Okay. So why is that? So why would that be? Well, it's a legal principle, actually. If I grabbed one of you, I'll pick on you. If I grabbed you and I put you in that closet back there and I closed the door and I locked the door and trapped you in that closet.
Involuntary confinement?
Okay, yeah, absolutely. Do I have the right? Now, I'm your teacher. It's my classroom. Do I have the right to do that?
I know we signed a bunch of stuff, but I don't
Yeah.
I don't remember some, but
Yeah.
Everybody's like, do I have a copy of that contract? Okay. So no other adult has the right to confine you to a space that you are not willing to be confined to. Does that make sense?
Yes.
At what age are you willing to give up that right?
No, you're not, unless the court takes it from you.
Ah, there it is. Okay. So there are only 3 types of people that can interfere with your right of self-determination, which means you're independent, you can do what you want, go where you want, you dictate your own journey in life, right? There's only 3 types of people that can interfere with that, and 2 of those are temporary. A police officer can restrain you. Police officer can put you in jail for a short amount of time. But who do you always get to see? The judge. Because with police officers, it is temporary. You have to have a judge, and in most cases, a jury, to make it any longer than what's in the statutes, temporary. Make sense? There's a whole process there. They can't just grab you up. You can't have a beef with some local cop and they grab you off the street, throw you in a jail cell, and there you're going to rot for the next 6 years. Doesn't work like that. It's all designed to prevent abuse of power, right? So that's the first temporary one. Over here, the temporary one is doctor. Same thing. A doctor can only restrain your freedom of movement for a short period of time. If we need it any longer, it's got to go to a judge. That is correct. So a judge, and in most cases, a jury with a judge, are the only people that can restrain you for any significant amount of time. Does not matter where you are. It does not matter how old you are. If we have a patient who is mentally incapacitated, it still has to go in front of a judge because their rights have to be removed. This is an extremely important legal principle that we cannot run over. And unfortunately, using side rails runs it right over. So short-term use ordered by a doctor, physically come in and reviewed, and anything longer than a certain period of time has to go in front of a judge to be continued. The right to self-determination is important. Make sense? Okay. So just remember, your patient must be in the middle of the bed at all times, the middle. Whether they're on their back or on their side, they need to be in the middle. Don't position them on their side close to the edge. And don't think a side rail is going to hold them there. Side rails fail. Okay. So we're going to scoot them toward us, and then we're going to roll them away so they're in the middle of the bed after the turn. We also want to make sure that when we're turning somebody, we're turning them away from us, not toward us. There's two reasons for that. Most of our weight is along the back side of our body. Gravity's going to try to pull you onto your back every time. If I turn somebody toward me, if I've got a patient in this bed and I turn them toward me, that means most of their body weight is way over there. If gravity tries to pull them on their back, I'm not going to be able to stop it. I'm too far away. Okay, so that's number one. Second reason, there's no easy way to say this. No easy way to say this at all. You never want your patient eye level with your crotch. Never turn them toward you. That is a triggering event for somebody who has had sexual abuse. Okay. They are dependent. They are vulnerable. They are laying down, and they are very minimally dressed. Think about the psychological impact of that for your patient. Okay. So we remain behind, the patient's behind. Good. So I just want to review this really quickly. There are, when we're talking about beds, there are 4 different adjustments for beds. There's head of the bed, foot of the bed, there's the entire bed high and the entire bed low. For this skill, we are going to be making a bed. You can bend, it's okay. You don't have to raise the bed up to make the bed, but it's probably going to be easier if you raise the whole bed up to a comfortable working height so you don't have to bend so much. But at the end of the skill, if you raise that bed up to a comfortable working height, what do you need to do? Yep, the lowest possible setting. So in most cases, we don't need side rails. We actually have beds that go all the way to the floor. These things are amazing. It's kind of like toddler beds. So they'll be sitting up like this. We'll get our patients in them, and then they get lowered all the way to the floor. That way, if the patient rolls out of bed, they're rolling onto a mat. They're not falling. If they want to get out of bed, they can get out of bed. But it provides safety without the use of side rails. I just went to a conference back in July, and I meant to grab this. I meant to put this picture up here, but I didn't. But I'm going to, hold on one second. I'm going to find this. They had a bed there, and it just blew me away how low they can get these things now. I mean, I know they've had low beds forever, but this thing was like crazy low. So I want to show you guys a picture of this. Man, between my puppy and granddaughter, I've got a lot of pictures of them. Okay. So I'll walk this around. So look how low that bed goes.
Oh, Lord. They look broken.
So this is a low bed. So we can use these with patients that are fall risks.
Oh,
Yeah.
broken. That's incredible. That's incredible.
Yeah, so those of you, I don't know if you guys can see that.
Bring it a little closer to the
Looked
camera.
like they were putting it together before
Yeah.
the frame.
Yeah, exactly. Exactly. So if we have a patient who is at risk, we may order a low bed like that rather than using side rails. We may have a bed alarm that lets us know when somebody gets up out of bed so somebody can go check on them and walk with them to make sure that they're safe. We have some alternatives that we can use. Side rails shouldn't be our first line of defense. They have a lot of risks with them. Good? All right, so skills specific. Let's talk about the steps that we need to take to do this skill accurately. And I've gone over most of this with you. We're going to keep the patient from lying on the bare mattress. We don't want them on the bare mattress. We talked about that. We're going to replace the sheet on one side of the bed at a time. So clean rolls toward me, dirty rolls away. So we're going to change the sheet on this side of the bed, go over to the other side, change the sheet on that side of the bed. If you have the patient on their side when you're changing the sheet, they take up less space. So it makes it easier. You can do it with them laying on their back, but it's easier if they're on their side, right? They have a smaller footprint. So we'll remove the dirty bottom sheet, secure the clean sheet on the mattress corners, remove any wrinkles, replace the top sheet, make hospital corners. You want to loosen the sheet over the toes so it doesn't bend the foot forward. You want to replace the pillowcase and limit the amount of time without a pillow. Just, again, comfort. We all know that comfort component to this. So any questions on this? Any questions? All right, I'm going to show you the video for this. The video has good close-ups of all of those steps. So let me get that ready for you.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good. How are you?
Wonderful. I need to change your sheets. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back.
Okay.
We'll start out with a barrier. I'm going to get a top sheet, a bottom sheet, and a pillowcase, and a privacy blanket. Okay, Mr. Jones, I'm going to place this blanket over you. This will help protect your privacy and keep you warm while we do this skill, okay?
Okay.
Okay, I'm going to spread this out. Can you hold that blanket in place?
Yes.
And I'm going to remove the sheet from the bed. We'll place the sheet in dirty linen. Mr. Jones, can I get you to scoot toward me, please? Thank you. And can you roll up so that you're on your side facing in that direction? Thank you. I'll remove the two corners of the sheet from this side of the bed. And I'm going to roll the soiled sheet in toward the patient tightly. I'm going to tuck it up underneath the patient all along the length of his body. Now I'll take the clean sheet, unfold it, spread it out on the mattress, and attach the corners. Now I'll roll the clean sheet toward me. We'll roll it so that it's tight with no wrinkles as we tuck it under the soiled sheet. Okay, Mr. Jones, come on back onto your back. And I need you to scoot to the center of the bed, please. Thank you. Can you scoot toward me, please? And can you roll so that you're laying on your side facing away from me? Thank you. I'll now remove the sheet from the bed that was soiled, wrapping it into a ball. And I'll go place this in dirty linen. Now I'll unroll the clean sheet and secure the corners on the mattress. As I do so, I'll make sure to stretch the sheet so that it's flat and minimize the wrinkles that are underneath the patient. Okay, Mr. Jones, can you come back onto your back, please? And scoot to the middle. Thank you. I'm now going to place the top sheet over you. And I'll remove that bath blanket now. We'll roll it in a ball and place it in dirty linen. Now I'm going to secure the sheet. I'm going to lift the mattress and smooth the sheet down so that it's flat under the mattress on both sides. Now I'll make hospital corners by lifting the top edge of the sheet about a foot from the end of the mattress, straight up. It'll form a triangle. Everything else will get tucked underneath. I'll repeat that on this side. And I'll loosen this over his toes so he has some wiggle room. There, how's that, Mr. Jones?
Perfect, thank you.
Very good. I'm going to remove the pillow from under your head. I'll bring it right back. I'll remove the pillowcase, being careful not to allow it to touch my uniform, and lay the pillow on the overbed table. We'll place the pillowcase in dirty linen. I'll take the clean pillowcase and scrunch it up all the way to the edges. We'll put the tag side in, place the pillowcase on top of the tag side of the pillow, and pull the sides down. I'll now place the pillow under his head with the opening facing away from the door. How is that, Mr. Jones?
Perfect, thank you.
Are you comfortable?
Yes, ma'am.
Here's your call light. If you should need anything at all, please don't hesitate to call. Can I get you something like a magazine?
No, thank you.
Okay, I'm going to open your curtain and wash my hands. The barrier will be thrown away. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right, any questions? Any questions on that?
Well, I wanted to ask a question, but that would make me sound like a student, wouldn't it?
No questions, sir.
I was gonna say, what if they're like an amputee, no arms?
Then your care plan would tell you how to adjust the skill for that patient.
Okay. I was gonna say, because like I can't think of any other way other than like maybe put the blanket underneath their chin, having.
You could just hold it with one hand as you're pulling the
Okay.
sheet down with the other.
Alright,
Yeah.
Yeah, but she was just asking if
Yeah.
you could, and if you can, allow them to do things that they can do.
Right, right. You can also tuck the blanket underneath the shoulders to
Okay.
hold it in place. So, yeah. So, and this is where you would want to work with your nurse because they may have some tips and tricks and things that they've discovered throughout their career that you might find useful. And remember, this is the beginning of your CNA training, not the end. You're going to be learning all throughout your career.
I did notice you did not snap or shake the clean ones.
Right. You don't want to snap or shake anything.
Okay.
Anything. Because that just aerosolizes whatever's on the bed. All those skin cells.
Why does it matter which way the pillow's facing?
Good question. Yeah. So a lot of visitors and staff members walking in that hallway, they are all breathing out, which means there may be things on air currents. Pillows, inside pillowcases, the surface of the pillow, we drool when we sleep. So the surface of the pillow is often warm, dark, moist. So you don't want anything to come in on those air currents and be able to get in underneath that pillowcase. So if the opening of the pillowcase is facing away from the door, there's no limited intrusion. That's a very old nursing principle, very old. Nobody's going to mark you off if you have the pillowcase facing the door, but it's something that I want you to kind of think about and be aware of, particularly if you're working in an area that is working with an airborne illness. So like COVID numbers are going up again, right? So this is something that if I were working on a COVID unit, this is something I absolutely would implement. Yeah. If I'm working on med surge, just a regular, hips and knees, I'm not going to worry about it as much. Okay. Good. All right. So we are actually going to come back to respirations. So I'm going to work that into a little bit later on in the program. I need to get into blood pressure. I need the time to be able to teach you blood pressure. So we're going to come back to respirations in just a little bit, or in the program, probably Wednesday. But let's go to page 56. The good thing about blood pressure is that it is not on the state exam. You will not be asked to perform this skill on the state exam. It is a non-tested skill. That does not mean you don't need to learn it. You do. A lot of places use automated cuffs. You put the cuff on, you press a button, it gives you some numbers. Great. But if that cuff gives you an abnormal reading, then how do you know that it's not the cuff that's wrong? Yeah, so anytime we have an abnormal reading on an automated cuff, we have to double check it manually. So you do need to learn how to do this skill. But it's not one that's going to be on the test. So let me explain to you what a blood pressure is and how this works. So inside your chest, you've got a heart. On the left side of your chest, the heart squeezes. When it squeezes, it pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes the one in front of it. We've heard this before. We heard this with pulse. We actually put our fingers down and felt those thumps as they moved underneath our fingers, those waves. Instead of counting the waves like we did with pulse, what we're going to do is measure how much pressure is inside the artery when a wave moves through and how much pressure is in between the waves. So in order to understand what this really kind of means, I'm going to give you an example. It doesn't have anything to do with blood pressure. If you've got a faucet on the outside of your house, and you've got a hose hooked up to that faucet, and you go out to the faucet and you turn it all the way on, lots of water is going to come out of that hose. The hose is actually going to expand and get a little bit harder because the pressure inside has increased, right? We have water pressure inside. Now we turn that faucet off. The water trickles down, the hose gets squishier, smaller, less water comes out, right? Less pressure inside the hose, no water. So all your heart is doing here is turning the faucet on, off, 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 on, off. So what we want to know is how much pressure is inside that hose when the faucet's on, how much pressure is inside that hose when the faucet is off. That's what a blood pressure is. In this case, we're measuring how much pressure is inside the artery when a wave moves through and in between waves. Okay, make sense? Kind of, sort of, a little bit. Okay, so let's take that hose for a minute. It's outside in the Florida sun beating down on it. If we turn that faucet all the way on, tons of water coming out, sun beating down on it, and we leave it that way for about 10 years. Water running. So lots of pressure on the inside, sun beating down on the outside. What's going to happen to that hose over that time? It's going to expand and eventually it's going to split. So yeah, it'll split because it had a lot of pressure inside and a lot of stress outside, the sun. In the body, we call that an aneurysm. When the blood vessels split because of the increased pressure inside and the stress outside. That is what an aneurysm is. Yes. Yeah. Good. So it probably would be a good idea to turn the faucet down a little bit. So we look for high blood pressure. That means a lot of pressure inside the artery. And if we can find high blood pressure, we can give that person some strategies to turn the faucet down a little bit to make those arteries last a little longer. Make sense? That's why we're concerned about high blood pressure. So normal values, this is where we want our patients. For the top number, when a wave of blood is moving through, maximum pressure, we want it to be somewhere between 100 and 119. That's ideal. That's what we want. Bottom number or diastolic, that's in between your waves. That number should be, in a perfect world, between 60 and 79. So systolic, top number, 100 to 119. Diastolic, bottom number, between 60 and 79. What would we do if we got a blood pressure that was higher than those values? Tell the nurse. What would we do if we got values that were lower than those numbers? Tell the nurse. So all we're going to do is take blood pressure and try to find abnormal. But in order to find abnormal, we have to know normals. Now, abnormal is if either one of those are off. So if I've got somebody, I get their blood pressure of 126 over 72, it's still abnormal. Even though the 72 is okay, the 126 is high. So if one number is off, top or bottom, it still has to be reported. Okay. You can actually see these normal values. Oops. On page 57 in the first column, the first paragraph. And then on page 50, I have a chart with all vital signs. 51 has an activity that you can use to determine abnormal. Just a really good documentation activity for you for abnormal values. So questions so far? Do we understand what a blood pressure is? The amount of pressure inside an artery as a wave moves through, and the amount of pressure inside the artery in between the waves. Anything abnormal, we report to the nurse. So how do we get a blood pressure out of all of that? How does this actually work? Well, in order to get those numbers, we're going to have to use a gauge. This gauge right here is called a sphygmomanometer. I know. We all just call it a blood pressure gauge. It's a little bit easier. But its technical name is a sphygmomanometer. And this is going to measure the amount of pressure. And it's going to give us some numbers. Well, how do we know what numbers? Well, what we're going to do is use a blood pressure cuff. We're going to fill it up with air and it closes off the artery. This is actually a tourniquet. We're stopping the blood flow, closing off that artery. When we close off the artery, the heart is still beating. Better be, because otherwise we're dead. So our heart is still beating. And other waves are going to join that first one and kind of line up. So you're going to get this line of waves waiting to move through. Okay. We open that cuff little by little by little by little by little, and the artery starts to open little by little by little by little. And it's going to be too small for the waves to move through at first. And eventually, as it opens, it's going to get wide enough for that first wave to force its way through. And when it does, it hits the top of the artery and makes a thunk sound. Where the needle is, when we hear that first thunk sound, the number that needle is pointing to, that is the top number of your blood pressure. So we inflate the cuff, we deflate the cuff. It's going to be quiet because we're slowly opening up that artery. The waves can't move through yet. And then we're going to hear our first thunk. That means the first wave moved through. Where's the needle? That number is our top number. Well, if the first one made it through, others can go. So you're going to hear more thunks. Thunk, 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 thunk. That means more waves are going through. Thunk, thunk, thunk. We don't care about those. We don't count them. They make no difference. They don't matter. What we're listening for now is the last clear thunk sound. But the problem is you won't know it's the last one until no more show up. So you kind of have to pay attention to each one because you don't know if it's the last one. Okay. So we're going to inflate the cuff, deflate the cuff. It's going to be quiet, 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 thunk. Whatever number the needle's pointing to, that's your top number. Thunk, 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 thunk. Oh, the last one was about here. So whatever number the needle's pointing to is your last one. Bottom number. You're going to keep deflating all the way to 0. That's the blood pressure. It's not hard. There's no math. We inflate, we listen. Listen for the first, listen for the last. Don't let the needle stop. Okay. We're going to get to that. So as a CNA, we do normal. You've heard that before. We do normal. So as a CNA, we are going to inflate the cuff up to somewhere between 160 and 180. We don't go over 180. We don't go over 180. Over 180 hurts. What effect do you think pain has on blood pressure? What does pain make blood pressure do? Yeah, it makes it go up. So if we're just looking for a problem, did we really find one if we actually caused it? Hard to tell, right? So we only go up to somewhere between 160 and 180. That's it. And then we're going to start to come down. It's going to be quiet. There's not going to be anything happening. This is dangerous for you, though, because sometimes your brain will try to talk you out of this because you inflated and it's quiet and it's quiet and it's quiet. I'm not hearing anything. Shouldn't I be hearing something? Maybe I missed it. What am I supposed to hear? Thunk. I don't know thunk. When I'm thunk, it's supposed to be thunk. Listening thunk for thunk. Oh. Don't stop listening. A lot of times your brain will get all wrapped up in this. Just inflate, deflate, and listen. That's all you got to do. Okay? Kind of shut your brain off for this. Your brain will try to talk you out of it. So we inflate. It's going to be quiet, and then we're going to hear the first thunk. Wherever the needle is at, whatever number it's pointing to is your top number. You'll hear more sounds, and then we're going to get to the last clear thunk. Wherever the needle is pointing, that number is your bottom number. And then we'll deflate all the way to 0. Now, these thunk sounds actually have a name. They're called Korotkov sounds. You don't need to know that, but, you know, it is nice to know. Korotkov sounds. So how far do we go when we inflate?
180.
Okay. And remember, normal for the top numbers between 100 and 119. There's a whole lot of quiet between 180 and 120. Whole lot of quiet. Some of you are going to have problems with the top number. You're my dreamers. And some of you are really going to have a problem with this. If you are the type of person where your brain wanders off, if it's not supervised, right? If I inflate the cuff and I have problems with this and I start to deflate the cuff, it's quiet, it's quiet. I wonder what I should Thunk have for lunch. Thunk. I heard Thunk today is National Thunk Hamburger Day. Thunk. And Thunk. Some restaurants, Thunk, have hamburger specials. Thunk. Right? If your brain wanders when it's quiet, you're going to have trouble with this. Now, on the other hand, the rest of you, you'll get that no problem. You'll have problems on the bottom. You're my dancers. You're my rhythm people. And what happens is we get a rhythm because the heart beats very rhythmically. And we get this rhythm as we're listening to these thumps. Thump, 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 thump. Did you fill in the next thump?
No, you imagined it.
If you filled in the next thump with your brain, you have to be careful because that wasn't a thump. So some of you are going to have trouble on the top. You're my dreamers. Your brain goes out and picks daisies. You're going to have to get your brain to focus. Some of you are going to have problems on the bottom because you're not going to be sure, did I hear a thump or did I imagine a thump? And some of you, like me, are going to have trouble on both. When I first started learning this, it was hard because my brain didn't know what to listen to. And it took a lot of practice. It honestly takes about 45 blood pressures before you really start to get this. So you got a lot of practicing in your future. Okay? About 4. You'll hear thumps. But for you to actually become accurate with this, it's going to take about 45 blood pressures. Okay? Don't be hard on yourself today. What's that?
I said I'm going to be taking my dad's blood pressure a lot.
Yes, yes. Anybody you can tackle. All right, so we're going to inflate our cuff to somewhere between 160 and 180. We're going to deflate our cuff smoothly. This needle should never stop. It should look like a second hand going in reverse. It should move very smoothly. Now you are in control of that needle. That is all you. I'm going to teach you how to do this in a minute, but it is all you. Okay? You are in control of that needle. If the needle stops, that's you. You did that. You've got to open it a little more so the needle moves. Just remember, whatever the needle is doing, that's you. You are controlling this. Okay? Good? So we're going to deflate. We're going to listen for the first thump. We're going to listen for the last clear thump. And then we're going to deflate all the way to 0. You're going to forget this because you're going to get so excited you heard thumps that needle's going to be hanging out somewhere over here. And remember, that hurts. That hand is going to reach up and slap you eventually. Get this air out of here. It hurts. So don't get so wrapped up in the excitement of, oh my gosh, I heard it, that you still have a tourniquet on your patient's arm. Okay. Good. Let's talk about our equipment. All right, so stethoscopes. Go ahead and pull out your stethoscopes. A stethoscope has 2 ends. It has a bell and diaphragm end, also called a microphone. That's all this is a microphone. And then these are your ear tips. So this is going to funnel the sound that this picks up to your ears. Pretty simple. It is an amplifying device. But let's talk about this real quick. So those of you that have a double-sided stethoscope, okay, may look like this, but if it's double-sided, this whole thing turns. The whole thing turns. So the problem here is that it can turn without your awareness. When you go to put it in your bag, it can flip over on you. And then you take it out of your bag this weekend to practice on somebody at home and you can't hear anything. So remember that this whole thing turns. Now, what I want to listen to is the large diaphragm because I'm listening for a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. This is not a big sound. I want a big microphone. But I've got to tell the stethoscope which microphone I'm using because only one is on at any time. I don't want to amplify all of this. I don't want to hear the lights or the fan or the AC or you guys moving. I don't want both amplified. So I have to tell this stethoscope which side I want to use. So down here where this joins the tubing is like a little adapter piece and one side is flat, has a little dot. The flat side or the dot side is your on side. So we want to use the big microphone and face it the same direction as the dot. Good? Everybody good? Okay, so let's move on to this now. So the ear tips are actually the most important part, and everybody gets this wrong. Ear tips, if they're straight, some of you have straight ear tips. They look like this. They're straight. We don't want straight. Our ear canals are not straight. So if you hold down here at the chin strap thing, you can actually turn these a little bit. So reposition them so they've got a little curve to them. Yours are preset. You'll want to curve yours a little.
How you curve?
There you go. Yours are preset. So come over there. Nope, they're not too curved yet. There you go. Yeah, probably just a little bit too curved. We're going to back that down just a tad. That's good. Yours are preset. Yours are preset. Yours are good. That's good. Okay. So when you put these in, okay, so they have a curve to them, right? They have a definite forward and backward. When you put these in, you always want them facing away from you. They face the patient. Don't put them in like this. They should never face you. In our world, it's all about the patient. So face this away from you and put them in your ears and very carefully tap your diaphragm. You should hear it very well.
And if you don't, turn it.
Yeah. Tap your diaphragm. Okay. Now take it out. Flip the whole thing around and put them in backwards. Then tap your diaphragm. Can't hear it as well. Probably can't hear much of anything. Take it out, turn it back the right way, put it back in, and try it one more time. We are trying to listen to a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. This is not a big sound, guys. Not a big sound. You need to make sure your stethoscope is in the right way for you to pick it up. Those of you who do not hear thumps today, the first thing you need to look at is, are my earpieces in right? This is the number one reason why you cannot hear blood pressure, is because you put this in backwards. Okay, good. Now, anybody watch medical shows at home?
Once or twice.
Yeah. Next time you watch a medical show, take a look at how they put the stethoscope in. Almost every one of them gets it wrong. And then you'll be able to say, oh, they did that wrong. All right, so blood pressure cuffs.
You always pull it out.
Hmm? Yep, go ahead and get your blood pressure cuffs out. So they go in just like that, just the way you've got them. All right, these are not one size fits all. They're one size fits most or one size fits many, but not one size fits all. If you're not sure whether this cuff will fit your patient, there on the professional cuffs, there is a white line on one of the short edges. This white line is your measuring line. This allows you to check to see if this is going to fit your patient. So if I'm concerned, can you come up here real quick? If I'm concerned, because she's got small arms, I'm thinking this cuff might be a little bit big for her. I want to check to see. I'm going to hold her arm out and the fold of the elbow right here. I'm going to take this white stripe and put it an inch above the fold of that elbow and wrap it around her arm. If it wraps more than halfway around, it's too big. If it wraps less than a third of the way, if I can't see either one of the corners underneath her arm, it's too small. Okay, thank you. So this white stripe, you put it underneath the elbow like this. And if it wraps more than halfway, it's too big. Less than a third of the way, it's too small. So this allows you to measure the cuff for the patient that you're working on. Okay. Good. All right. So you have a gauge. Remember, the gauge is a sphygmomanometer. On the back of your gauge is a little clip. If you press down on the bottom of the clip, the top magically opens. Ta-da! There is a fabric strip on your cuff. If you open your clip and slide it up the fabric strip, it will stay there. That's important because this thing is heavy. When you're putting this on and taking it off the patient, if this falls, what's right under it is the patient's wrist. And you can shatter their wrist. So you always want that gauge secured when you're putting cuffs on and off. Now, those of you, let me have this real quick. So you have one. Okay. Those of you, let me see this. Those of you, whoa, uh-oh. Sorry about that. Those of you who have this type of cuff where you have a metal bar, those of you who have a metal bar, you will not have, in most cases, the strip because this is a home cuff for you to take your own blood pressure. It's not really designed to be used on other people. This allows you, this metal bar allows you to tighten that cuff around your own arm. Okay, so if you have this, it's designed for home, which means if you have the gauge, you're not going to be able to see it. You want the gauge in front of you. Make sense? Okay, so the way that these work, this one's a little bit different. This one's a little, so we're going to, you put the free end through underneath the bar, and you're going to wrap it around and secure it. Okay, so that's how these work, but the gauge itself will just kind of lay on the table. Okay. Questions?
When you wrap the cuff around their arm, if you take the gauge and where would you put the gauge?
You always want it on that strip. When you're taking blood pressures on other people, never remove it. It should always stay there. You should never take it off. There's no need to. Okay. So let's talk about how to read this dial. You'll see it's marked in 20s. We got 20, 40, 60, 80, 100, and so on. The big lines in between are going to be your 10s. So if this is 60, that one's 70, 80, 90, 100, 110, 120, 130, 140, 150. The little teeny tiny marks are 2s. So if this is the line for 140, that makes this 142, 144, 146, 148, 150. There's no 1s on here. If you get a blood pressure of 131 over 99, I know you're guessing because there's no 1s on here. Right? Keep your numbers even. There's spaces, but you're not that accurate. Ever. Okay. Good.
So if it's in between the space, would you go down a number?
You aren't capable as a human of measuring an in between the space reading. So here's the thing. Okay. So we inflate the cuff and we deflate the cuff. Your hand is controlling the bulb and valve assembly, that needle. Your hand is controlling that. Your ears are listening for the sound. Your eyes are watching the needle go down. And the needle is always moving. Always moving. It doesn't stop. It should never stop. So you've inflated, you've deflated, the needle is moving, 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 moving. Where's my pen? Moving, 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 thump, 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 thump. We are not precise enough to identify a thump in a space on a moving needle.
130 over 60, huh?
Well, I wasn't looking. I was looking at you guys. Does that make sense? You're not that precise because the needle is moving. Okay, good. All right. So yeah, let's do a blood pressure. So if we inflate the cuff to somewhere around 180, we start to deflate, and our first thump is heard here, where this yellow line is. First thump is here. This is the line for 100. So 102, 104, 106. Our top number is 106. We're going to keep listening. Our last thump is heard here. This is line for 60, 62, 64, 60. Okay, so our top number was, bottom number is, that's our patient's blood pressure. They're normal. We like it. We like it. Questions? Okay. What's that? What do they eat? Not popcorn. That's for sure. All right. So look on page 57. And there's two pictures of blood pressure dials in the gray box. So question 8 and 9 are from the first picture. Question 10 and 11 are for the second picture. See if you can take a look at that. I know that's small, but see if you can figure out the patient's blood pressure. So number 8, what do you think this patient's blood pressure is?
130 over 90.
Everybody get that? 130 over 90? Yeah. Do we understand how we got that?
By 2 centimeters.
Okay. Is that a normal blood pressure?
No.
So what would we need to do?
Report to the nurse.
Okay, report it to the nurse. Now look at number 10. This one's a little bit harder. What is this patient's blood pressure? Okay. Everybody get that? 108 over 62. Do we all agree? Is that a normal blood pressure? Man, I would kill for that blood pressure again. I haven't had a blood pressure like that in forever. Yeah, most of our patients are going to have higher blood pressure because the American diet is predisposed to higher blood pressure. Okay. Questions? Are we good? Okay. All right. Rosanee says, Ms. Pat, can you please do a video titled 10 Things Not to Do in the CNA Prometric Exam? I think it would go viral, and then do one every year, things not to do in the CNA exam. That's a good idea. I'll take a look at that. Thank you. Thank you for that suggestion. Okay. So let me show you how this works. I'm going to use a can for the moment. Don't follow along, just watch. That's all I want you to do at the moment is just watch, okay? So I'm going to wrap this around my patient's arm. Right now I'm using a can, obviously, but I'm going to wrap this around my patient's arm. And when I wrap this around the arm, I want it snug. Okay, not like horribly tight. I mean, it still moves, but I don't want it so loose that it falls off. I need it snug. I want to position this on the patient's arm so that the gauge is facing me. Okay, the gauge should always be facing me. And my dominant hand, so I'm right-handed, my dominant hand is going to hold the bulb and valve assembly, this thing. And I'm going to hold it so that the tubing is up. This is not correct. We don't hold it like this. We hold it like this. And when I hold it, I'm going to hold it so that that dial, this little silver thing, is facing me. Okay, so I've got my patient's arm and I've got my dial. I'm going to close this righty-tighty, lefty-loosey. So I'm going to close this to the right, and then I'm going to inflate. Back up just a little bit here. Where am I going here? I'm going to inflate, and I'm going to slowly open that valve. Maybe you guys can see it on the screen. So that that needle comes down, and I am in control of that needle. I am in control of that needle. I never want it to stop. Remember I said that I don't want that needle to stop? That's all me. I have to control that with this little silver dial. So let me do that one more time, a little closer. So maybe I gotta get a light back here so you guys can see. Okay, I'm gonna open it up. So that needle comes down, and I don't want that needle to stop. So I'm opening a little more, a little more. See how the needle stopped? That's no good. Need to open a little more, a little more, a little more, a little more, a little more.
If it did stop, would you redo it?
Nope, just open it a little more. It's going to try to stop on you because the amount of pressure inside this cuff is diminishing as the air leaves. So you need to open it a little more so that more air can go out. Okay?
To have the dial loosen up to where you can do it with the finger.
So, right. So we're going to close it before we inflate because that closes the door so we can put air in. But you don't want to tighten it down because if you tighten it down, when you have to loosen it, you're going to have to go, ugh, and then all the air comes out at once. So this takes some practice. Okay. Very much so. Very much so. So that's what your hand is doing. So your hand's very busy. And we got to learn that part of it. We've learned what our ears are going to be doing because we've learned how to use the stethoscope, right? So we've learned what our eyes are going to be doing because now we know how to read the dials. So we have to put all of that together. Your hand has to control the needle. Your ears have to listen for the sound. Your eyes have to identify what number we're on. And your brain has to put all of that together. This takes some time. But I want to go back to what we first started talking about, the stethoscope. And I told you we were going to come back to this. Okay, so when you are listening to the blood pressure, you're listening for that thump, that karok cough sound, right? And I told you it's a wave of blood hitting the top of an artery buried under muscle, fat, and tissue, not a big sound. So when we're doing this, we've got to make sure that we have our microphone in the right place. So like I'm wearing a microphone here, it's picking up my voice because it's in the right place. If I take this microphone off and put it way down here, it's not going to be as effective because it's not going to amplify what I need it to, right? So what I want to make sure is that my microphone is in the right place. Your arm can't tell. This thing has no brain. I can't just slap it on the arm and hope for the best. I've actually got to find the artery. Anybody ever have your blood pressure taken? Where do they put the stethoscope when they're taking your blood pressure? Okay, it should be on the brachial artery, yes, but usually they just slap it right in the middle and hope for the best. It's actually not where your brachial artery is.
Is it right here?
So I'm going to show you guys. So if you hold your arm out, palm up, and get that elbow straight. Don't let it get lazy, right? You want that arm popped out at the fold. So where your lines are, 2 fingers. Do we ever use our thumb?
No.
Okay, 2 fingers, and it's going to be on the pinky side. So it's not right in the middle. It's more on the inner aspect. So if you put 2 fingers there and your thumb on the back, you should be able to feel your thumbs. Don't be right in the middle. Remember, if you're right in the middle, you're probably not there. You want to be on the inner aspect at the lines. So inner aspect at the lines. So you're on the outer aspect. You want to be here. Did you find it? So you're a little too low. We want to be at the
I found it
lines.
the other day. I was at home trying to mess around with the stethoscope.
You get it? Did you get it? Get it? Find it? Did you find it?
I mean, you have a coat on, bro.
Come down.
Let's
There we go.
take that off.
Okay. You're a little too close to the middle. Come to the inside a little bit more. Put your thumb on the back. Put your thumb on the back. Did you find it? Okay.
Towards your chest. The inner
Did you
towards
find
your
it?
chest. So here.
She's about a pinky.
No, it's the,
Right here.
she means in. So
Yeah, right there. Put your thumb on the back.
towards your chest. Right here. You'll feel it.
Yours is
I wanna
buried
say, it's
pretty
like
deep,
center,
so
then
close
go
your
a little bit
eyes.
below center.
And that
Yeah.
I'm
zeroes
so glad I
in.
caught you doing that.
Try to find hers. Hers may be a little bit easier. That's fine. That's fine. Were you able to find it?
Yes, I did.
Okay. So what I want you to do now is find somebody else's, please. Find a partner. Find somebody else's.
Pick an arm anywhere. They both work.
Yep, right in there. Put your thumb on the back. Chapter 4 and do the and do the questions. Remember to get your arm completely straight. Got it? Okay.
Really?
No, listen, I have high blood pressure. I know what it is.
Okay, did everyone feel somebody else's thumbs? Okay, so you know where it's at now. It's on the inner aspect of the elbow, but make sure you're at the lines. If I go too far down here, I've got way more tissue there. I'm not going to feel it. I want to be where the lines are on the pinky side. So if I just come along and throw a stethoscope right in the middle, I'm not going to hear what I need to hear because I'm not in the right place. Okay. So on your blood pressure cuff, just below your gauge, you have a artery marking. Could be a line with a circle. It could be a little patch like this. It says right arm, left arm. But when you're taking a blood pressure, and this is going to be the professional cuffs, the home cuffs may or may not have that. I don't know. Everyone's a little different. When I'm taking a blood pressure, I'm going to put this on the arm, lay it in place. Okay. So don't do this on yourself. You're going to do it on somebody else in just a minute, but you're going to lay it in place. I'm just going to show you on me. I would lay this in place, but not fasten it. I'm going to find my artery. There it is. There's my thumps. This is my left arm. So I want to move that left arm arrow over to where I feel those thumps. And now I have an X marks the spot. I know exactly where to put my stethoscope. So then I would secure my cuff, wrap it around my arm so that it's snug. But I want to make sure that this lower edge of the cuff is above where my stethoscope's going to be. Anybody ever have somebody take your blood pressure and they put the stethoscope underneath the cuff? Okay, so let me explain to you why that's bad practice. This microphone right now out in the open, it's picking everything up. What's going to happen if I do this? It muffles it. It deadens the sound, or what we call flattening the sound. I'm not going to be able to hear the good thumps I need to hear. When you put that stethoscope underneath the blood pressure cuff and inflate it, that's what you're doing. You're flattening that sound out, and it's going to be harder to pick up. And that means that we may be inaccurate in our reading. Does that make sense? Okay. So we lay the cuff, we find the artery, we line up our artery marking, we secure the cuff so it's snug, and make sure the bottom is at least an inch above the fold of the elbow. We're going to inflate the cuff. How far do we go? And then we're going to come down slowly, and we're listening for the first clear thump, and wherever the needle is, that's our number. We'll hear more. We don't care about those. We're listening for the last clear thump, and then that's our bottom number. And then we'll deflate all the way to 0. Good? Questions? All right, so a couple of helpful tips. When you are trying to find somebody's brachial artery, if they put their arm out and you're feeling and you're not feeling it, it's gone. I don't hear, are you alive? Right? Look to see, is their arm straight? If you pop that arm out, it'll automatically appear. If that arm is the least bit lazy, that artery dips down and you can't feel it. You want to make sure the patient is sitting with their arms supported on a surface. Don't have them hold that arm out, just waving around in midair. We need that arm supported on a table or the back of a chair or somewhere. So yeah, I'm going to set you guys up in 1 second. Feet should be flat on the floor for when we're taking blood pressure. Feet should be flat on the floor, uncrossed. Yep. Yep. Good? Questions? Okay. So whenever possible, if we always ask our patient, which arm can I use? You know, which arm would you prefer? Yeah, which arm would you prefer? So that's ideal. But that doesn't, it's not always, our patients may not always know, or our care plan may not specify. If there's no contraindication, we go with the left. If your patient says, oh, I don't care either one, pick one, go with the left, because there is a blood pressure difference right to left. Okay. It's a larger diameter artery. Yeah. So because it's coming off the heart, it's a larger diameter. So if we have a choice, left is best. Okay. Otherwise, we're going to listen to our patients.
Right as well.
Yeah. Okay, good. Questions?
What about patients that have like the birth control inside of their arm?
Oh, it's a very good question. So there's a lot of reasons why we would avoid a specific arm. Most of those are going to be on your care plan. Remember, your nurse has already done all your work for you. She's done the whole assessment, taking care of all of that. Follow your care plan. But if your patient's had a stroke and one side was affected, we don't want that arm. If the patient played Humpty Dumpty and we had to put him back together again, we don't want that arm. If the patient has an IV, we don't want that arm. If the patient's undergoing dialysis and they have a shunt or a graft, we don't want that arm. If the patient has birth control implanted, we don't want that arm. So we want the healthiest arm the patient's got, right? And our care plan will usually let us know that. If the patient's had a mastectomy, you absolutely want to avoid the side of the mastectomy. That's a breast removal. We trap fluid, right? This is a tourniquet. So all of that fluid that's in the arm gets trapped. Now, when we remove a breast, we also remove lymph nodes. Your lymph nodes are your recycling center. It would take all of that excess fluid and put it back in circulation normally. But if that system is gone, we just have fluid that doesn't go anywhere. So the arm will blow up like a sausage and it won't ever go down. So the next question is, well, wait, what if the patient's had a double mastectomy? What if they don't have, what do I do then?
CNAs do normal.
Say it again.
CNAs do normal.
Yeah, is that normal?
No.
Who would do that one?
Nurses.
Not our problem.
Oh Lord.
Okay. Good. This is why CNA school can be 4 weeks. Nursing school is 4 years.
Because it's not our.
Not our problem. Okay, good. Good. All right. So I'm going to have you three work on that chair. Okay. So you'll be the patient. She's going to take your blood pressure. Then you'll become the patient. And you'll take her blood pressure. And then you'll become the patient and she'll take yours. Okay. So you three are going to work together on that chair. You two are going to work together on this chair. So you're just going to kind of turn it around so that your arm is supported on here. Okay. So you'll take hers. She'll take yours. When you're done, you'll switch into other groups. Okay. Because I want you guys to take, hold on. I got a whole nother section I got to tell you about. I want you guys to take at least 3 blood pressures on at least 3 different people before we're done today. But I'm going to give you cans in just a moment, and we're going to practice inflating and deflating before you start working on real people.
So,
Do you have enough hands?
so
Yes.
say I mess up my blood pressure reading on the arm that I'm doing right now.
Okay.
Can I do that arm again?
Great question. So what if I don't get the blood pressure the first time? So our rule is, it's a very, very good question. Our rule is you can try twice on one arm and then move to another arm if you need, move to the other side if you need to. And then if you don't get it, move to another patient. So twice on one side, other arm if you can, as long as there's no contraindications. If you still don't get it, another patient. Somebody else will have to take that blood pressure later. Okay. So right now I'm going to pass these out. And this way you can practice inflating and deflating your cuff. So practice inflating and deflating the cuff. You've got one. These are all ones that students have brought in and just left for me. So, okay, those of you with home cuffs, you're going to have to take turns because you need something bigger. These cans won't work for you. So this is the only larger one I know. It's the only larger one I have. So you guys will all have to kind of take turns, okay?
Can I also get one?
Oh, yes, absolutely.
I would have, used my cup here, but it's very squishy.
Yeah, no, it'll squish. It will absolutely squish. Okay. Yeah, you guys will just have to wait just a moment. And can you put that over there for her, please? Oh, I got it. Okay, so you're going to wrap your cuff around your can. You want the gauge to face you. You're going to hold it in your non-dominant hand because that one's going to hold the blood pressure or the stethoscope in a minute. You're going to hold the gauge in your dominant or the bulb and valve in your dominant hand. Close that silver dial just until it closes. Inflate up to somewhere between 160 and 180. Bless you. And then slowly open that dial to the left until that needle comes down. And this is what your needle should look like.
You said to 180, right?
Yeah, 160 to 180.
We didn't know something already.
Yep, a little too fast. There you go. So we want that needle to move. Opening it. There you go. But it's not a crock pot. You can't set it and forget it. You got to open it a little, open it a little, open it a little, open it a little, open it a little. Go ahead and give it a couple of tries. That way you get the hang of it. And then once you think you've got the hang of it, you're going to work with your partners and take blood pressures. So when you're holding this, so first thing we're going to do is make sure that this is
What speed you got? Same speed I got.
you may want to slow it down just a little bit because remember your eyes, your ears, and your brain all have to work together. So you want this like snug around here. So hold this in your non-dominant hand. Hold this in your dominant hand. You want to hold it like this. Nope. Like this. So you're going to take your thumb and forefinger and turn this to the right. Okay. So turn it to the right. And then you're going to squeeze until the needle goes up. So squeeze. Let me close it a little bit more. Hold on. There we go. A little bit more. Okay, now take your thumb and index finger, hold on to that, and turn it that way just a little, nope, little bit. Teeny tiny bits. So close it. Teeny tiny bit. Teeny tiny bit. So watch how little I watch when I'm holding this. Watch how little I move this, okay? So if I inflate it, see how it's between my thumb and index finger? You see how little I'm moving that? See, it's just tiny, 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 like a hair. All right. Questions? Clear as mud?
No.
Yeah, just about.
Just about. All right. So I'm going to have you three working together. If you can use that chair on the end, just kind of turn it so it's facing that way so they can support their arm on the table. Okay. I'm going to have two. See here. So those three are going to work together. You two are going to work together. You three are going to work together. Okay. Make sure that the arm is supported on a table. Okay. Make sure the arm is supported on a table. So, yep, just work together. She should be.
Oh, and Did you want to start?
And you guys can work on this chair if you want to so that you guys have more room. One second. Stay. Okay, so we're going to work on your right arm today. So we're going to lay this over the arm. Make sure it's at least, an inch above the elbow. We're going to find that artery. There it is, right there. Yeah, we're lined up. So we're going to secure this.
Are you sure that's where my pulse would be?
Okay. Now put your stethoscope right here. Make sure your earpieces face away. Yep. Nope. Nope. Yep. Put it on there. And you really want to kind of squish that in so it's got a really good seal. There we go. And then you're going to hold this. Yeah, there you go. A lot going on, isn't there?
It's still coming out. Did you turn it all the way right?
Inflate, deflate, and listen.
Try that.
Okay, you need a stethoscope. Do you have a stethoscope? Okay, so let's put this in. We're going to put this. We're going to move this up just a little bit. Okay, I'm going to put this here. Squish it in there really good, and then inflate, deflate, and watch.
How about it?
Wake it up. It's trying so hard not to laugh.
It might be too big for you.
You guys can work together. Grab a partner. If you see somebody sitting around, put them to work. Yep. Can I get through real quick? I'm sorry. Nope. See, maybe come over this way. That way I could thank you, just so I can help. Okay. Sure. So I'm going to ask you to extend your arm as much as you can. Okay, it's right here. Do you see this right here? This is a tendon. Hers is actually under that tendon. So I'm actually kind of pushing that tendon to the side a little bit. And when you do that, man, she's got a nice strong one right there. Got it? We'll get you a partner in just a second.
Usually, I'm not sure if I'm controlling the pressure correctly.
Okay, let me come.
I feel like I'm letting.
Oh, you need, okay, let me get you some stuff.
I feel like I'm releasing too much air, so
Okay.
I'll tighten it. And I'll add. So when I use the release, I can add too much.
What was the what?
Yeah, so instead of just using your thumb, if you put your finger, loosen up your finger real quick. Put your finger here on this side. Put your thumb here. And now you've got more control. Okay, you'll have more control. Yep. See how much more control you have? Okay. I have no idea, but that's okay. All we're doing right now today is practicing.
Pretty much first day of the year, you'll see it where. Yeah. Yeah, so pretty much like as soon as you like get to 180, let some air loose. As soon as like you hear the first pump, you would like mark that like the first number. And then pretty much as it goes down, you'll hear the last pump, whatever. Yes.
About to choke your arm out. I didn't.
That one's going to be a little bit lower just because your arm is a little larger. So
I can still hear it.
that might be just a little too, I'm going to adjust this just a little bit. It's a little too much. There we go. turn your whole stethoscope around. You want them facing, there you go. You want them facing away.
I mean, I could hold. I gotta see it.
Okay. All I remember was a 120, like somewhere around there, and then around that 60. Let me retry that. Your arm killing you yet?
I didn't pay attention when the first stuff came, but I heard it.
Okay. Go ahead and let all the air out. There you go. Hearing Thumps is what the name of the game is today. I just want you to hear it.
Trying to figure out. I'll let it out. Well, I was trying to figure out.
No, it's okay because that side isn't on. It's better to kind of hold it on the side. Well, she may have a very low diastolic, and that's okay. That's okay. Can I have you guys work?
Yeah, it sounds about right.
Or, are you guys, one of you available? Are one of you guys available?
I don't know if you got my reading.
Okay, because we got somebody who hasn't worked at all, hasn't been able to practice at all.
I got you. All right. Come here, I come there, whatever you want.
I was gonna say, you take mine, I take his. Okay.
I'm gonna gauge faces.
Okay.
You will, yep. I know I had just the right amount of people, but somebody left, so.
Not hurting you? No. Okay. That's hard.
It is hard. It is.
That's not too tight, is it?
Since this is like a self-measuring, I can do it for myself, couldn't I?
That one you can, yes. Yeah. It's designed to tighten that's the biggest problem is you don't have enough. You can't tighten the cuff when you're doing a regular one on yourself. Because you haven't taken one at all, right? You haven't tried this at all?
I never tried this.
Okay, then go ahead and try it because we're pretty much out of time here. Go ahead and finish up the one you're working on, please. Go ahead and finish up the one you're working on. Let all the air out.
Don't forget to let the pressure out if you're done. Let all the pressure out. Yeah, because you like let it go and I was like, oh, someone took me out. No, it was like when I was first starting with my friend. That's what she told me. Just make sure you let all the pressure out.
Oh yeah, no. I did it with them on the other day.
Yeah.
Put your earpieces in. We're going to move this up just a little bit here.
Over 60. Okay. That makes sense. It is.
There we go. Go ahead and put the stethoscope here. And you want it, this is your non-dominant hand. You want to hold it in place really nicely. Go ahead and inflate.
So what if you get 119 over 60? Is that normal? That's normal?
100 to 119 is normal for the top. 60 to 79 is normal for the bottom. So yes, it would be considered normal.
Well, yeah, I just wondered if the range was going to be any different. I figure if it's like 100, it should be toward the 60, and if it's like
Nope, you can have a high systolic and a normal diastolic. You can have it can be off in either direction on either number.
What did you get on that again?
I got 130 over 82.
There's a number.
Yeah.
So we keep your blood sugar. Okay, 136.
Now we're doing our more deeply tested.
And my gate
Well, we're out of time.
Oh yeah.
So let me give you your review sheet. All right. We'll finish up this last one and then let me wrap this up. Oh, thank you. All right, this is today's review sheet. You don't have to worry about answering the ones on respirations because we did not get to that skill today. We will cover it in a later class.
What is it? 8? 4, 7.
See, 6, 7, and 8. You won't have the answers to. Yeah. All right. You probably have zero confidence in this yet, and that's okay. Did everybody hear at least one set of thumps? That's what I'm looking for. Did you hear thumps? If you heard thumps, I can let you loose on the general public. Please don't get stuck, right? This is a tourniquet. The more you take it, the higher the blood pressure goes because it's reacting to the stress of being closed off. So don't get stuck on one patient. Don't take somebody's blood pressure over and over and over and over and over and over and over. Twice on one arm, move to the next arm, move to the next patient. Try not to only practice on one person because everybody's blood pressure sounds a little different. If all you're practicing on is one single person, you're going to think that's what all blood pressure should sound like, and you're going to get stuck later. So get a variety here. Homework is chapter 4. That's why I go over homework at the beginning of today's class, because I know at the end you're all about the blood pressure. But please remember, you're going to read chapter 4. You're going to take the test and the spiral book for chapter 4 and grade it. When you come back to class on Wednesday, we have other skills to go over. We have one more principle to learn, and then you have those principles. We'll just recycle them for future skills. Okay, we will work respirations in. Don't panic. I'm not going to leave you hanging. I've got a little time to play with a little later on in the program. Good? Questions? Do you feel okay with what we went over today? Okay, am I going too fast for anybody? I don't want to leave anybody behind. If you feel like you're struggling, please make sure you come back and let me know. Okay, there. A lot of information, guys. 4 weeks is a very short time to get all of this down. I don't want anyone to feel like they're drowning. Okay, good. All right. I will see you on Wednesday. You do not need to bring your blood pressure cuffs and stethoscopes to the next class. But if you want extra practice, when I open it up for practice, having them with you may be helpful. Okay? Have a fantastic day. Today is National Burger Day. Lots of places have good burger specials. So if you're looking for lunch, there's an option.
Speaking of burgers, anybody want a slice of pizza? Come on.
Thank you. My balance is off.
Bye-bye, guys. Oh, I'm good. Thank
I
you.
will take a slice later. All right. I had extra plate.
That's super sweet.
Can I throw it in your trash?
Absolutely. Yeah, if you want to use that one over there.
I'll just pay you.
Thank you.
you have a nice weekend with your friends?
I did. It was awesome. It was amazing. Yeah, I came back very refreshed.
Yeah. Sometimes it's needed.
Yes, it's definitely needed.
Always needed.
All right, YouTube world, I'm going to go ahead and sign off. Please remember, tomorrow is the game show. Tomorrow at 11, we'll do 15 practice test questions for the written test, and you have the opportunity to win prizes. So tune in tomorrow at 11 for the game show. We'll be back live for our classroom on Wednesday. And then Thursday, I have my weekly live session as well. So lots of opportunities this week to join us. Other than that, I'll see you guys on an upcoming episode. Until next time, happy caregiving. Bye.